Moving on to a newer topic where art meets science and talking about the miracle of life and letting you know that even miracles take a little longer. Coming forward next is a story of hope because hope is the only thing stronger than fear. Because when the world says give up, hope whispers try one more time. Moving on to the next session on IVF, I would like to call upon my dear friends and colleagues as chairpersons, Dr. Maya Ben Joshi, a senior gynecologist practicing in Bhavnagar for the past 25 years, who has served the Surti Hospital as well as the G3 Medical College in various positions. Madam, most welcome to this session. Next is a very dear friend, Dr. Medha Kanani Shah, who is currently an associate professor at Shantaba Medical College and General Hospital, Amreli, and also serves as the consultant at Soul Healthcare, Bhavnagar. She is working at First Choice IVF Center, and her area of interests are infertility, ART, endoscopy, and high-risk pregnancy. So we have this young and dynamic chairperson now with us. So over to you, chairpersons, for the session. Can you, ma'am, please introduce the speaker for the day?
Hello, good afternoon, everybody. Dr. Hitendra Somani. He is DNB, FICOG, FMS, FIAGS. He is Diploma in Reproductive Medicine in Europe, Fellowship in Reproductive Medicine in Chennai, Diploma in Laparoscopy in Germany. His position in Joint Secretary in Indian Fertility Society Gujarat Chapter, past President Bhavnagar Obstetrics and Gynec Society. He is affiliated in Director at Nirmal IVF Tube Baby Advanced Laparoscopy Center Bhavnagar. He was awarded in FICOG at AICOG in 2015 Chennai, Best Paper Presentation Award at Yuva ISA 2014 in Jodhpur, Divya Bhaskar Award 2018, Eminence Award for Best IVF Center in Saurashtra region. He received Atmanirbhar Award at Gandhinagar 2021. He published many national journals, presentation paper at many national and state level conference, attended many national and state conference as a faculty speaker and panelist. He has special interest in infertility in elderly patients. Now, Dr. Somani sir.
Thank you, ma'am, for the kind introduction. Good afternoon, everyone. I'm Dr. Hitendra Somani, practicing infertility specialist. We run a dedicated, focused IVF center at Bhavnagar. Today, we are going to discuss IVF at glance. See, infertility may be defined as failure to achieve a clinical pregnancy rate after 12 or more months of regular unprotected sexual intercourse. For any couple who is less than 35 years of age, and 6 months for the couple less than 40 years of, about 35 years of age, and 2 months for the couple who are more than 40 years of age. All in all, around 8 to 20% of the people suffer from infertility. If we consider 100 people get married, out of them 85 will become pregnant in first year, 7 in the next year, 1 in the third year. So as the age increases, fertility decreases. This is especially true in the case of female. If you look at the causes of infertility, 30% is the male factor, 30% is the female factor, combined is 10%, unexplained is 25%, and others is 5%. So what we are going to discuss is what is IVF. For whom we do IVF, that is indications of IVF. What we do in IVF, that's the procedure, the good effects, the bad effects, some evidence-based facts, and newer developments. So IVF derived its name from the fact that fertilization occurs outside the woman's womb in a test tube. So it is known as test tube baby also. The world's first test tube baby, Louis Joy Brown, was delivered in 1978 in Britain. So what are the indications? Tubal factors, male factor, which can be mild or moderate, or severe endometriosis, ovulatory dysfunctions, uterine factors, fertility preservations, and pre-implantation genetic testing. What actually we do in IVF, what do we do? How is the procedure? So egg production is stimulated by hormone therapy. Then eggs are retrieved from the ovary. The sperm sample is collected and prepared. Both of them are combined to allow fertilization. And this fertilized embryo is in turn kept inside back into the uterus. Let us look at some videos. So this is the process of natural fertilization. In this case, the follicle starts forming. The dominant follicle is selected. It reaches somewhere around the period of ovulation, and under the effect of LH surge, the ovulation occurs, whereby the mature oocyte is released, and it's picked up by the cilias of the fallopian tube. At the same time, if they have a relationship, the fertilization occurs into the fallopian tube. The endometrium, under the influence of progesterone, becomes secretory and receptive to embryo, and embryo eventually gets implanted inside the uterus. Next slide, please. I'll make it fast because this is a little slow. Nature always goes slow. So what we do in IVF is that, see, semen is easily available because it can be collected by the person. But we need eggs, more success. So we give injections for 10 to 11 days. We started from day 2 with sonography. On day 8, we give antagonist to prevent the side effects of gonadotropins and recombinant FSH, which we use for the growth of the follicle. After giving antagonist, somewhere around on day 11 or day 13 or day 12, when the follicle size is around 20 millimeter, we give trigger. Trigger can be agonist or it can be a HCG trigger. This trigger causes the final maturation of the oocytes. And exactly at 36 hours, we do pickup. Pickup means we extract those oocytes, and in the laboratory, we mix it with the sperm of the husband, make an embryo. If this embryo is to be transferred in the same cycle, then we start progesterone. And after 3 or 5 days, we transfer it back into the uterus and do beta HCG after 14 days. If it is not to be transferred in the same cycle, we do process of freezing. That embryos are frozen and they are kept in liquid nitrogen at minus 180 degree. They are kept alive. We fill every 3 days. Till we can keep it legally up to even 10 years. Next slide, please. So what happens actually in ovum pickup? This is a transvaginal probe of ultrasound. We put it inside the vagina and we attach it with a biopsy guard. We pass a needle. The needle is almost like a sword. This needle enters into the pelvis through vagina from the fornices. We go to the ovaries, penetrate the ovary, reach the follicle, and extract the follicular fluid out of it, which contains the oocyte cumulus complex. So where there is a oocyte, see, this is how under sonography we pick up. And this goes into the test tube, which is taken into the laboratory, and then we process it, and further process will come on. So this is OCC. We will process it. Next slide, please. So
Once
now,
the oocytes have been obtained, they are left in a culture medium distributed in 4 wells. Parallel to this, semen obtained through masturbation is prepared, separating the
semen
mobile
is
from the
processed,
immobile
washing
sperm,
is done.
and then concentrating them. There are 2 types of insemination of oocytes, the conventional way and using ICSI. In the conventional way, a micro droplet of concentrated sperm is added to each of the wells containing the ova.
in ICSI, they are allowed to mix normally.
Insemination,
In
one of the
IVF, they are
sperm
allowed to mix
the tail
normally.
is immobilized and is aspired into a fine needle. The oocyte is fixed with a micropipette and the other side is pinched by the needle and the sperm is injected into the oocyte.
This was the process where sperm was picked up, it was immobilized by cutting off the tail, and good morphological sperm was directly injected with an injecting needle inside the oocyte. So ICSI is specifically used when there is a male factor, when the morphology is poor, when the count is extremely low, the ICSI is very helpful. Next. This is embryo transfer. In this process, we collect the embryo, and this is done without anesthesia, just like a simple IUI procedure under transabdominal ultrasound guidance. We pass it through vagina from the cervix, and we enter inside the uterine cavity, though it looks a very simple procedure, but it's very complicated, because if the embryos is not placed properly, the entire procedure will fail. If we put more fluid, if we give more head low, or if they are pushed a little up, then it will result in ectopic pregnancy. If they are put at lower level, then it will result in abortion. So transfer is the most important part of IVF. Next slide, please. This is about laser hatching and embryo biopsy. We'll cut it short because of time constraint. Next. So about third-party reproduction. It is a process wherein third person comes to help in the process of reproduction. This third-party person may be a donor or maybe a surrogate. It may be a sperm donor, maybe a oocyte donor, maybe anonymous, maybe a known. In surrogacy, it helps to carry a pregnancy for the couple. If we look at donor oocytes are the one, when they are indicated in case of ovarian failure, very low AMH, postmenopausal woman, and passing on some significant genetic defect. Donor sperm is when there is no male partner, that means a single woman. If you are not able to get sperm by ejaculation, by ICSI, by TESE or micro-TESE, then we have to go for donor semen. Donor embryos are not legally allowed. They are allowed only if it is from a donor sperm and donor eggs, which is used for untreatable infertility and infertility due to embryonic causes. A word about surrogacy. It is derived from the Latin word subrogate. That means it is appointed to act in place of. Actually, surrogacy is an arrangement in which woman agrees to carry a pregnancy that is genetically not related to her and her husband, with an intention to carry it to the term and hand over the baby to the genetic patients, parents for whom she is acting as a surrogate, basically a kiraye ka ghar. So there are two types of surrogacy. One is traditional, which is no longer allowed, in which the semen is inseminated into the woman and woman becomes the biological mother. Gestational surrogacy is in which the embryo is generated by the oocyte and sperm of the same couple, and the embryo formed is put into the womb of some other woman who is acting as a surrogate. This is particularly useful when lady is having a uterine anomaly. Or there are some cardiac conditions, some medical conditions which are contraindication to carry on the pregnancy. Let us look at the non-desirable bad effects. There are multiple pregnancies, ovarian hyperstimulation, adnexal torsion, hemorrhage, needle injury, bladder, vessels, ectopic, heterotopic pregnancy, pelvic infection. Like IVF is like car is driven at the speed of 20. You take it to the speed of 400. If you're unable to control it, patient will end up in ovarian hyperstimulation, patient will go in ICU and may die also. So that process is entirely controlled ovarian hyperstimulation. Many times patients question me that if I go for IVF, will there be any chance of more congenital malformation? Answer is that larger and reliable survey says that there's no major difference between the babies, in terms of malformation, between the babies delivered by IVF, ICSI or natural conception. So more or less the congenital malformation rate is same. Some patients who are azoospermic, where we do testicular extraction of the sperm. So in such cases also, there is no difference in major congenital malformation rate when we compare testicular sperm as well as the ejaculatory sperm. Long-term outcome, there do not appear to be major effect on the neurodevelopmental outcome, but more number of preterms and extreme preterms because of the twins and triplets. The entire cohort of IVF babies is moving little slower than the naturally conceived babies. Initially, semen analysis was done manually, where people were just looking at the microscope. It was subjective. There was no objective proof. So CASA has come, computer-assisted semen analysis, where the computer tells about the motility, count, and morphology, which is more of objective, reproducible. We can give photograph and CD to the patient and can decide whether the patient will conceive naturally with IUI or with IVF. A word about IUI. In IUI, this is CASA picture. The IUI is what? Actually, in IUI, the sperms are prepared and they are inserted into the uterine cavity through a cannula which we pass through the cervix. The advantage is what? The sperm falls near the tubal ostia opening, so it has to travel a shorter distance to reach the oocyte, which is released at the time of the ovulation. But IUI success rate is very limited, 10 to 12%, at the most 50% if the patient selection is proper. So type of treatment, 10 to 15 million, timed intercourse and natural treatment. 5 to 10 million, we can go for treatment with IUI. Less than 2 to 5 million, we can try with IUI treatment and we can go for ICSI. If the count is less than 2 million, bad morphology, motility, we have to go for ICSI. So now newer development, whenever there is a mushrooming of clinic, the government comes in the picture. The government has come out with ART law 2021. This is just like PCPNDT law or pollution control law. Only difference is that there's so many criminal offenses and punishable crime up to the 8 years. So this is a very strict law. It says level 1, IUI can be done, level 2, IVF can be done. Any person who doesn't have recognized clinic cannot do any ERT procedure. That means a pathology lab can do the semen analysis, but they cannot do IUI wash semen because it is an ART procedure. Any person who may be qualified but cannot do IUI unless the clinic and the person is registered with ACT. Second is that age limit, the maximum limit of the mother, up to 50 years we can do. Previously we were doing so many elderly patients like 63, 65. Now it is not allowed. 50, we have to check their birth certificate, we have to check their marriage certificate, whether they are married or not, but no IVF beyond 50. Donor from the ART bank, sperm donor from the ART bank, oocyte donor from the ART bank, just like a blood bank. Donor has to be fully investigated, insured for 1 year. She can donate only once in a lifetime. Surrogacy, the laws have become strict like kidney transplant. It is only altruistic. No professional surrogacy is allowed, no foreign surrogacy is allowed. And cannot use donor gametes. You have to use their own gametes to do surrogacy. Permission from the state board is required. Government is allowed IVF for single women. So these are new developments like oocyte. See, more and more women are now working. They plan marriage late, they get married late. So the facility for oocyte freezing is for what? That they go for pickup, their oocytes are frozen. Subsequently, when they get married or when they plan pregnancy, the same oocyte and the male partner, they can make the embryos. Oncofertility is a developing branch. In this case, if the cancer is diagnosed, if before puberty, then we can remove the ovarian cortical tissue, preserve it in liquid nitrogen, can use it when her cancer is cured, when she gets married, and when she is prepared to have child, we can transplant it again, and from that we can make her own oocyte and she can become biological mother. If cancer is detected after puberty, and we have a time of stimulation, then we can make the sperm, and if we have a sperm spouse, then we can make the embryo. If she's not married, then we can do oocyte freezing. If the cancer is detected and cancer surgeon says that we have no time, we have to do it immediately, then we can do IVM and ovarian tissue cryopreservation. Even the cancer patients have right to become biological parents. We are doing community service by those, there are many, 2-3 medical students who have undergone testicular orchidectomy. We have preserved their sperm and done a freezing, and we keep it alive with liquid nitrogen. So this, in newer development, there are better embryo selection techniques like time-lapse imaging, embryoscope, sperm selection, DNA fragmentation index. About success rate, on an average, fresh embryo transfer success rate is nearly 35%. Frozen embryo transfer success rate is 47%, and carry home baby is 30%. If someone says it is 70%, the person is right and wrong. Wrong because it cannot be 70%, right because it is a cumulative pregnancy rate. They do one pickup and transfer in 2-3 cycles. So it becomes a success of 70%. PGT, where we detect abnormal embryo, and there are 3 types of PGTA. We do embryo biopsy and detect for aneuploidy, detect for single gene disorder, detect for structural rearrangement. Development of NIPGTA is a process where we detect abnormal embryo without doing biopsy. But remember, nature is very powerful and nature is very beautiful. Embryo has capacity to auto-correct itself. Many times the reports are such that it is an abnormal embryo, but eventually it turns out to be a good embryo and gives a good pregnancy without any kind of malformation. So last two slides, the AI, artificial intelligence, is the future of IVF. AI in oocyte selection, AI in sperm selection, AI in embryo selection, and in future we are going to have designer babies. Road to success is a journey. IVF is very unpredictable, and there is no 100% success anywhere in the world. So it comes with dedication, training, vast experience, state-of-art setup, accreditation with the national board, no-batch systems, standard drugs, quality control, best incubators, and highly ethical practice. Thank you. Thank you so much for patient hearing. It was a pleasure. Thank you, IMA, for giving me opportunity to be here. Thank you, chairpersons.
Thank you, sir. It was really a very informative lecture. From audience, if anyone has any questions to sir regarding ART or IVF, as we have still time left, so session is open for any question.
Wonderful elaboration.
Thank you, sir.
One question I want to ask, as you mentioned about the surrogacy. Surrogacy. So what are the legal boundaries? Can you explain about the surrogacies in India?
See, there are so many litigations going on, specifically against one doctor in Anand, because she made embryos before the law came in. And the day law came in, she could not do transfer. The law is so strict that there's an imprisonment of 8 years. You are generating babies, you are giving life, you are creating babies, and if you create without law, it becomes absolutely illegal. Surrogacy is basically only genetic parents can avail surrogacy. That means their oocyte, their sperm, and woman who is known to her, no paid surrogacy. They cannot do any kind of payment. There is no payment for that surrogacy. And foreign surrogacy is not allowed. And it has to be done by state board, means there are 4 layers. 4 layers, first is at district health, then it goes to the joint secretary of the Gujarat state, they pass it, they send it to the medical board checks it, then there is a psychiatric verification where the couple is capable enough to keep the baby. All these things are done. And it is like Abhimanyu ka kotha. And most of us, previously, if 100 people were doing surrogacy, now only 4 or 5 people are doing surrogacy. So OCI cards are allowed. OCI cards are allowed. Only foreign nationals, those who are having foreign nationality. Indians.
Can an Indian couple go outside India?
They are allowed. They are allowed.
They are allowed. Like somebody goes to Dubai or Singapore. And
overseas Indian card holders are allowed, sir.
No, the Indian citizens going to Dubai and getting it done or.
Sir, if they go to Dubai, they get it done. It is their problem. But Indian government is very strict because some people were doing sex determination in Dubai. In Dubai, PGT and sex determination is allowed.
Right.
Their phone calls were traced in Delhi, and they were taken to the task. The government is right behind those people who are doing sex determination.
No, but about the surrogacy.
About surrogacy, sir, if they do, but they will not get birth certificate in India.
Okay, I mean, the event happening in Dubai and then they travel back.
So how they will
and
get birth certificate in their name? Main problem of surrogacy is what? Somebody becomes pregnant in your place, but you want a birth certificate in your name. How it will come? Okay. Government will give only if the birth is in India.
Right.
Thank you, sir. Thank you very much.
Request the chairpersons to felicitate the speaker. I would like to call upon Dr. Heenal Gujarati, consultant at City Children Hospital, and Dr. Neepa Gohil, madam, consultant ophthalmology, to do the honors and felicitate the chairpersons. Dr. Heenal and Dr. Neepa, please.
Moving
Dr.
on to
Heenal
next.
is our tireless worker who has been working behind the scenes since the past 2 days and many more. 2 days we have witnessed her, and she's been a tremendous support here backstage.
Moving on to next session, multiple myeloma. For that, I would like to invite on stage the chairperson, Dr. Parthiv Mehta and Dr. Pradeep Joshi. Sir, please come on the stage. Dr. Parthiv Mehta is a practicing hemato-oncologist, associated and director as Jeevandeep Multi-Speciality Hospital, Bhavnagar. Dr. Pradeep Joshi has passed his MBBS and MD from BJMC and ex-president IMA Bhavnagar and API Bhavnagar. He has delivered talks on vitamin B12 at API Hyderabad and Ludhiana. He has been a chapter written in Medicine Update book of API and delivered many talks in national and state level conferences. Sir, now it is your...
I welcome Dr. Manan Waghela. He is a DM medical oncologist. He passed his DM from Gujarat Cancer and Research Institute in 2016. He has a thesis of clinical profile of patient of imatinib resistant in chronic myeloid leukemia chronic phase. He was a principal investigator in many of the trials, particularly trastuzumab and other in breast cancers. He has organized a conference and workshop in young medical oncologist at Ahmedabad. At present, he is practicing at HCG Hospital, Bhavnagar, since last around 2 to 3 years. Okay? Okay. I welcome you. He is going to speak on multiple myeloma. Though the plasma cell neoplasm is a spectrum of the disease, multiple myeloma is one of the end of that spectrum. We rarely diagnose the cases like monoclonal gammopathy of unknown significance, smoldering myeloma, plasma cell myeloma. Most of our patients come and diagnose with multiple myeloma. So he will guide us how to initially diagnose these patients with his clinical features, what are the investigations, what is the treatment. Over to you.
Thank you, Jimacon, for providing a wonderful opportunity to present lecture today. And thank you, sir, for a kind introduction. Today's my topic is multiple myeloma, clinical features, diagnosis and treatment, and can we do better? So first of all, what is the multiple myeloma? Myeloma is the cancer of the plasma cells. When there is uncontrolled proliferation of plasma cells, it leads to the multiple myeloma. As per the incidence, multiple myeloma accounts for around 1.8% of all the cancers, and it accounts around 20% of all hematological malignancy. Median age is around 65 to 70 years. And whenever there is a abnormal proliferation of one clone of plasma cells, it will lead to the multiple myeloma, and that plasma cell secretes a particular type of antibody. So this antibody is called as the paraproteins, and this paraprotein gets accumulated in the different organ of the body, which leads to the clinical manifestations. When these paraproteins get accumulated in the bones or renal, it will lead to the renal damage. Disease can present with anemia, immunosuppression, and bony pains. So what are the etiological causes? As this is a cause is not known at present, but it is seen more frequently in patients who are from low socioeconomic status, who are the farmers, maybe because of DDT exposure, wood workers, leather workers, sheet metal workers, or the survivors of nuclear war. Multiple myeloma is seen more commonly in patients who have radiation exposure. There is increased incidence of pre-malignant condition, that is known as monoclonal gammopathy of unknown significance, in the patients who are exposed to the radiation. As per the pathophysiology, as we can see, this is the normal plasma cells. Some kind of translocation, which may be because of some prior infection or inflammation, which leads to the pre-malignant condition, that is known as the monoclonal gammopathy of unknown significance, and over the time patient may develop second mutation or which can convert into the multiple myeloma. In the pathophysiology, there is a increased bone resorption at the bony site, and there is increased angiogenesis. So because of that bony resorption, patient presents with bony lytic lesions. Now how does the myeloma present? It is one of the malignancy which presents very later and diagnosed at very late. Why? Because the symptoms are not specific, there are vague symptoms, and it leads to, it delays in the diagnosis of, and the most common presenting symptoms are the back pains. Almost 40% of the patients have the history of back pain. That can be vague bony pains and non-specific body pain also. Patients may present with the anemia or respiratory symptoms. Some patients may present with neurological symptoms. Now, in the physical examination, most common finding is the pallor, and some kind of hepatomegaly can be seen. And some patients may present with extramedullary plasmacytomas, which can present as lymphadenopathy. Neurological presentation, this is the when if the patients diagnosed in very later stage, they can present with the neurological symptoms. The worst of this is cord compression. Whenever the patient diagnosed in late stage, there can be a plasmacytoma collection or soft tissue formation in the bone, or there can be weakening of the spinal bones, which leads to pathological fracture, which leads to the cord compression. Some patient may present with radiculopathy. This can be because of the compression of the existing nerve roots, and some patients present with peripheral neuropathy. Mostly they are the part of the amyloidosis. Other complications with which patient can present is infection, mainly streptococcal or gram-negative infection. As we have seen, there is a abnormal proliferation of plasma cells. So, normal plasma cells are not able to secrete antibodies. So, because of this, patients are at high risk of developing secondary infection. Now, we come to the how to diagnose a myeloma. So, first, the only hematological abnormality seen in the peripheral smear is anemia, as well as increased Rowlax formation. So, patient might have elevated ESR count. In the biochemistry, there is elevated total proteins. Along with that, there is increase in the monoclonal proteins. This is the characteristic lab investigations. As we have seen, the myeloma cells that secretes the single, there is a proliferation of single clones of plasma cells. So, this clone secretes a specific protein. So, when we do serum protein electrophoresis, we will find an M band at the particular site. Why? Because there is a secretion of a particular protein from the single clone of plasma cells, which can be characterized by serum protein electrophoresis or by urine protein electrophoresis. This is the picture showing a monoclonal M band in the serum protein electrophoresis, and if we want to quantify which kind of antibody are secreted, then we can quantify it on the basis of immunofixation. Now, monoclonal protein can be either IgG, IgA or IgD. Most common monoclonal protein is from the IgG category. Now, as we have seen, this plasma cells are derived from single clone. So, either they will secrete a light chain, either it can be a kappa or it can be a lambda light chains. So, on the basis of free kappa chains and lambda chain analysis, we can diagnose a single clonality of the cells. So, on the basis of free light chain ratio, we can diagnose the multiple myeloma. And FLC ratio is also useful for the light chain only disease, because in light chain only disease there will be only secretion of light chains, there will be no M bands, but patient will present with urinary proteinuria and albuminuria, and in these patients there is elevated FLC ratio. Additional lab investigations include beta-2 microglobulin, which is elevated in most of the cases, albumin which might be decreased, and as in other lymphoma, LDH may be elevated because of accelerated cell proliferation. Now come to imaging studies. Over the time we require different kinds of modality. Most common abnormality seen in X-ray is osteolytic lesion. There can be a multiple osteolytic lesion. Whenever almost 30% bone are eroded, then patient develops a lytic lesion on the X-ray. If you want to diagnose the lytic lesion earlier, then we can use either CT, MRI or PET-CT. MRI is particularly useful to diagnose a solitary plasmacytoma, in which the patient might have only lytic lesion on only one part of the body. This picture is showing punched out lesions on the X-ray. Yeah. Now, how to confirm the diagnosis? These are the supportive investigations. If you want to confirm the multiple myeloma, then there must be an elevated plasma cells in the bone marrow. So, we do a bone marrow biopsy from the posterior superior iliac span. We aspirate the bone marrow aspiration and also take the bone marrow biopsy. And on the bone marrow aspiration, this is the slide of bone marrow aspiration. It clearly shows the blue cytoplasm as well as eccentrically placed nucleus, and there is a perinuclear hollow. This is a characteristic features of plasma cells. Now, on the bone marrow biopsy, we can do immunohistochemistry to define the single clonality of plasma cells, as well as we do chromosomal abnormalities, either normal karyotype or to be specific FISH study. This is a normal karyotype which shows chromosomal abnormality, as well as the FISH study to define the specific mutation which are associated with multiple myeloma. This FISH study is very useful because on the basis of particular mutation, we can diagnose the risk of the patient. We can stratify the patient whether it is a high risk or a standard risk. So, on the basis of FISH study, these are the, if we found translocation 414, translocation 1416, translocation 1420 or deletion of 17p or TP53 mutation, these are the high risk features, and this patient needs to be treated aggressively. Other standard risk features include trisomies, translocation 1114 and translocation 614. So, if the patient is having more than one high risk mutation, then these patients are defined as, if they have two high risk mutations, they are defined as double hit myeloma, and if patient is having 3 high risk mutations, then they are labeled as triple hit lymphoma. Why? Because it is important, because if the patient is having high double hit lymphoma or triple hit lymphoma, they are most likely to be refractory to the therapy, and they are at higher chance of developing early relapse. So, we have to treat that patient aggressively. Now, this is the criteria how we diagnose the multiple myeloma. For the diagnosis of multiple myeloma, if we have a more than 60% plasma cells in the bone marrow biopsy, then it clearly defines that patient is having multiple myeloma. If the patient is having less than 60% plasma cells in the bone marrow, then we require some additional features which are characteristic to the disease. These are include, there is a synonym, that is slim CRAB. So, first these are the CRAB features. One is the elevated serum calcium level, that is more than 11 mg per deciliter. If patient is having less than 60% plasma cell, but patient is any one of these features, elevated calcium, renal insufficiency, anemia that is defined by HB less than 10, lytic bony lesion which is defined by either X-ray or MRI or PET-CT, and associated with that, if we have increased plasma cells anywhere between 10 to 16% in the bone marrow, and FLC ratio that is altered either in the range of more than 100 or less than 0.5, and MRI finding suggestive of more than one focal lytic lesion, the patient is defined as a multiple myeloma. Then there is another terminology, that is smoldering multiple myeloma. In smoldering multiple myeloma, patient have serum protein electrophoresis shows more than 3 gram per deciliter M spike. Patient may have plasma cells in the bone marrow between 10 to 60%, but there is no end organ damage. So, these are in the other terms, smoldering myeloma is termed as a asymptomatic myeloma. Over the time, smoldering myeloma may convert to the active disease or active multiple myeloma. And one thing is, one terminology is MAGUS, monoclonal gammopathy of unknown significance. It is defined as a M protein less than 3 gram per deciliter. In the bone marrow, clonal plasma cell are less than 10%, but there is no myeloma defining events. Now, this MAGUS is a pre-malignant condition. Most of the patients who are diagnosed having multiple myeloma, previously they may have passed from the MAGUS state if the patient is having high risk features like paraproteins level more than 1.5 gram per deciliter, or patient is having IgG disease or abnormal FLC ratio. If the patient is a Megas patient shows any one of these risk factor, there are high chances of this patient to convert into active multiple myeloma. So if you have a patient of monoclonal gammopathy of unknown significance, you look for these high risk features, and if the patient justifies these high risk features, any of this, then you should keep the patient on regular follow up whether the patient is developing myeloma or not in future. This is the natural course of the disease. Now how we will stage the multiple myeloma? We are using beta 2. Previously the ISS staging was using beta 2 microglobulin and albumin. On the basis of 3 stages are defined. Currently it is revised stage is used, which includes FISH study as well as the LDH level. On the basis of this we define the patient, and after that we start the treatment as per the risk status. This is the in general treatment paradigm. First of all, when we have the myeloma patient, we stratify them, and after that we assess whether the patient is eligible for hematopoietic stem cell transplant or not. If the patient is eligible for hematopoietic stem cell transplant, then we give them an induction therapy, around 4 to 5 cycles of induction therapy, followed by stem cell harvest, and then we do autologous stem cell transplant, followed by maintenance therapy. And after completion of maintenance therapy, we put the patient on regular observation, and over the time the patient will relapse, because currently there is no curative therapy for multiple myeloma. We can prolong the disease or we can increase the overall survival, but because of the advances in the treatment, the overall survival has increased from the 2 years to around 5 to 7 years for the multiple myeloma. And if the patient is not eligible for hematopoietic stem cell transplant, then we put the patient on continuous maintenance therapy. Which are the molecules we use for the treatment? So previously steroids, alkylating agents like cyclophosphamide and melphalan and anthracycline were the agents used for the treatment, but over the time we have developed some newer classes which includes immunomodulators like thalidomide and lenalidomide, and the proteasome inhibitors like bortezomib. After the invent of these molecules, the treatment has changed very well, and the overall survival of patient has increased from 2 years to 5 years. Currently we have further molecules. If the patient has progressed on this molecule, we have additional novel drugs which includes carfilzomib and ixazomib. In immunomodulators we have a pomalidomide. There has development of specific antibody. As we know, the plasma cell express CD38 on their cell surface. So we have a specific antibody against that CD38, and this is elotuzumab and daratumumab. Now what are the guidelines? How we start the treatment of the patient? First, we assess the patient. If the patient is less than 60 years of age and without any comorbidity, patient is able to take the side effects well, then we start with the triplet regimen, which includes one of the immunomodulators like pomalidomide or lenalidomide or thalidomide, and proteasome inhibitors, either carfilzomib or bortezomib. And if along with that we use the steroids, because steroid is also cytotoxic for plasma cells. If the patient is very fragile, who is not able to tolerate triplet regimen, or who cannot withstand the aggressive side effects, then we start them with the 2 regimens, doublet molecules, either proteasome inhibitors with Dexona or immunomodulators with Dexona. Most of the patients present with a bony pain. In these cases, we require to administer radiotherapy to the patient. So we can't wait for the radiotherapy to take the charge. We administer systemic therapy along with the radiotherapy, and as we have discussed, over the time patient will relapse. The in general guideline suggests that if the patient relapse after 6 months of therapy, then we can again re-challenge with the same molecule. These are the NCCN recommended guidelines for the first line treatment. As we have discussed, the first time treatment includes bortezomib, lenalidomide and dexamethasone, or either carfilzomib, lenalidomide and dexamethasone. maintenance therapy, if we have used lenalidomide, then we put the patient on lenalidomide maintenance. If the patient is having high risk, then we can also put the patient on bortezomib maintenance. Now, this is the flow chart how we assess the patient and start the treatment. First, we will do the FISH analysis, and on the basis of if the patient's having high risk features, then we put patient on the either the daratumumab or carfilzomib or bortezomib along with pomalidomide or lenalidomide and Dexona. If the patient is eligible for hematopoietic stem cell transplant, then after 3 to 6 cycle, we offer the patient autologous hematopoietic stem cell transplant. And if the patient is not suitable for transplant, then we continue the primary induction therapy for around 1 year. Now, the role of bone marrow transplant in multiple myeloma, there are two kinds of bone marrow transplant. One is the autologous bone marrow transplant, and that is allogeneic stem cell transplant. If the patient is less than 65 to 70 years, and we preferred mode of transplant is autologous bone marrow transplant because of less morbidity and similar response with autologous transplant. If the patient is less than 45 to 50 years, we put them patient on and relapse, then we can consider for allogeneic transplant in this patient. In tandem transplantation, we offer autologous stem cell transplant twice. After the induction therapy, we offer first transplantation. When the patient recovers from toxicity, we do second transplantation. This is the natural history. Once we start the treatment, the myeloma cells subsides and patient goes in the remission. Over the time, their relapse will happen, and we again start with the second line or third line of therapy, and patient will come into remission. But the remission which was achieved in the first line therapy may not be able to achieve after the second line, and over the time patient will relapse second or third time, and patient may go into refractory disease. Now, these are the treatment of relapsed multiple myeloma. It is just 1 minute.
Please summarize.
Based on the previous treatment, if the patient has received lenalidomide, we offer other kinds of molecules, and if the patient has received patient did not receive lenalidomide, then we can offer these are the molecules. And management of bone disease, as we have discussed, the patient present with lytic bony lesion. Some of the patient present with paraplegia or pathological fractures. So we use the bisphosphonates, which are anti-resorptive agents, and along with bisphosphonates, other molecule that is used is the denosumab. Because bony pain and fragile bone must be addressed, and this leads to the permanent disability. If we don't address the lytic bone, patient may develop paraplegia over the time. So bone health should also be checked at regular interval, and patient has to receive either denosumab or bisphosphonates. These are the supportive cares as we have discussed. Bisphosphonates, along with it, patient may require radiotherapy, immunoglobulins or plasma exchange. So, any question?
Thank you, Manan. You have made the difficult subject very lucid. In the 90s, when we were in the MBBS, there were only 2 lateral X-rays to be put in the MBBS examination. And we remembered like that Vashram Bhai is multiple myeloma and Sharda Ben is widening of the pituitary fossa. So that was the only multiple punched out in the skull lateral X-ray, and the only treatment was the omnocotin. From that we have come a long way to the monoclonal gammopathy of unknown significance. But would like to make just one comment. We just recently, me and Parthiv, we are both from the same unit. We came across a case where MBAND was positive, and we investigated the patient, and it was ultimately the COX, tuberculosis. So just like rheumatoid factor positive is not always rheumatoid arthritis, same way MBAND positive is not always multiple myeloma. Thank you.
Thank you, sir.
I request chairpersons to felicitate Dr. Manan. I request Katrodia sir to felicitate chairpersons. Thank you, Katrodia sir. Thank you, Dr. Parthiv. Thank you, Dr. Pradeep.
I'm sure Dr. Makad would be a proud teacher today. having two of his residents together on stage. Moving on to the next session of the day, where we talk about self-preservation, because self-preservation is the first law of nature. In this era where we are transplanting knee joints, hip joints, and whatnot, today we have a young surgeon who is going to talk about preservation of the knee joint. And to chair the session, may I now call upon Dr. Sanjeev Ravi Saheb, who is trained in robotic TKR surgery. He is a senior consultant and director at the Department of Orthopedics and Joint Replacement at BIMS Hospital, Bhavnagar. And he deals with polytrauma very routinely and is a robotic knee replacement surgeon. We have our enthusiastic chairperson, Dr. Nisarg Shah, who is a consultant at Sri Bajrangdas Bapa Arogya Dham, Bhavnagar, as well as at Hanumant Hospital, Mahua. His special areas of interest are endoscopic spine surgeries and sports medicine, the need of the hour. Over to you, chairpersons.
Good afternoon, respected seniors and colleagues. On behalf of HCG GMACON 2023, I invite our speaker, Dr. Ujjwal Deliwala, who has dedicated his 15 years of professional life to knee and shoulder arthroscopy, sports injury, and joint preservation surgery. Due to his excellent academics, he has been selected for various international fellowships at world's most reputed institutes like Hospital for Joint Disease and Sunnybrook at Canada. He has also received international training at multiple international institutes like Portugal, Chicago, Germany, Singapore, Italy. He is founder member of various societies in India like Cartilage Society and various arthroscopy related bodies. He is regularly presenting to various national and international conferences, and he has been given international awards for that too at ISACO Scholar, at ICS Cartilage Society, and at ESCA. He is practicing arthroscopic surgeon at Deliwala Hospital, Bhavnagar, and caters to patients from Gujarat and outside even. And over to you, sir. Today is going to talk about preserve your knee joint before it's too late. I think it's going to be useful for everyone here.
Thank you for the nice introduction. It's really honor to hear with all my senior respected seniors and colleagues, because this is the most important slide. As I started my first presentation with GMACON before 15 years, and this is my firm base platform. So I'm very much thankful to all the seniors and colleagues over here. Because of them, I turn out to this whatever present level. Regarding any future things, we are in 21st century. We are more concerned with what will be the next. But we are not worried about when patient or our own relative ask about knee pain. Because of these reasons, we are struggling with the thinking about future. Why? Because of unwillingness of knowing what is going on. We are not referring or we are not taking experts' opinion. And if some experts are giving some decisions or some treatments, we are not following. And regarding that, and we don't know what is going around in the world. So if you see, the joint preservation is the most upcoming branch of the orthopedic. And if we ask me, out of 10 knee arthroscopy, currently 50% arthroscopies are for preserving the joint. How? I will convince you within, suppose 20 minutes, right? So we have to think why the younger patients are suffering with knee joint pain. And we all agree that old patients will with old knee, that is dictum, but young patient with old knee, what is that? Because of the alignment of the knee joint, high BMI, neglected knee injuries, lifestyle, sedentary, gym-related injuries, sports participation increase, as well as neglected to the whatever pathology is there. So, but patients are weekend warrior. They are not doing regular exercise, right? And they want active lifestyle. They want pain-free functional activity. But how we can give this? So the objective of my talk is to convince regarding the knee preservation, minimum invasive procedures. Apart from the surgeries, there are some non-pharmacological and non-operative treatment also. And after all, to prevent major surgeries in early future, this was the symposium created, right? If we see the the magazine, in Time magazine, very early in 2003, they says the epidemic of arthritis. So it's not early, but we are facing with another epidemic, that is unnecessary surgeries done. So knee replacement is one of the unnecessary surgeries done apart from the cataract and hysterectomy. One of the leading joint replacement surgery, I must agree that Ravi Sahib will also agree that there are 300 to 400% increase in the revision TKR surgeries, and 1 out of the 5 consulted patients, if they are diagnosed early in their life, they can be prevented with joint preserving surgeries. So we have to take care about this. So I must agree and must appreciate the government initiatives regarding joint replacement. It is wonderful surgery, give excellent outcome in indicated patients age over 60 with severe osteoarthritis. But at the same time, if it is done in an unindicated or overuse, then we should be ready with the upcoming epidemics of revision TKR, which is a high-end surgeries and which cost a lot. So if we go to this game-changing slide, that 78% of the TKR patient, if they were evaluated retrograde, they have neglected meniscus injury. So meniscus injury leads to no meniscus and no cushion effect and rapid progression of arthritis. So this is how the concept of joint conserving surgeries is come, right? So look at this patient, 47 age, pain on the medial side, and 9 months of pain. I must agree that what should be done at this 9 months pain with bone-on-bone disease, right? There is no cartilage over here. So any kind, I must say that orthopedic surgeon sitting over here will be agree that apart from the total knee replacement at the age of 47, a kind of unicondylar replacement should be offered. So why this happened? There is a rapid progression of arthritis. Look at these x-rays. These are the weight-bearing x-rays. With meniscus tear, at the 3 months, arthritis has been started, 6 months, rapid progression, 50% loss of the cartilage, and 9 months, complete loss. So now there will be metal inside the joint, either partial knee replacement or total knee replacement. So save the meniscus. Meniscus acts as a cushion effect. It acts to avoid the shock absorbing from femur to tibia. It acts as a cushion. So if we don't save the meniscus, that lead to rapid progression of arthritis, and abscess of meniscus leads to 132% increase in total knee replacement. So to prevent this kind of major surgeries, we have to respect meniscus. Look at this patient, female, 38, 3 months pain only. There is no joint space reduction, and we can evaluate this patient with MRI. There are classical signs of meniscus injury, and we can definitely repair meniscus. So partial meniscectomy, which was done previously, even I burned my hands in my initial practice, but that should be contraindicated in meniscus injury, right? Nisarg Bhai will be agree. And what should be done? So meniscus should be repaired. Now the very tiny instrument with tiny holes, we can repair this meniscus. And this is the short video. With 4 mm hole, we just pass the various motorized shaver and various instrument. We tie the meniscus, and we stuck the meniscus to from where it detached. So that will again recreate the cushion effect of the knee joint, and the joint will be preserved. At the 6 months, patient can cross-leg sit, can sit, our religious activity, our Indian toilet, everything can be done. What else you can offer at this age, 38? So this is how the female is enjoying her base jobby, like enjoying Garba. This is what our Indian patients require, right? So this we can't give with any kind of major surgery replacement or any other. So apart from the meniscus repair, there are other minimum invasive procedures like PRP injection, stem cells therapy, high tibial osteotomy, ligament. If ligament is torn, we can do ligament reconstruction. Various cartilage procedure can be done. If the ligament is torn, here we can also add ACL repair concept. So now newer concept is to repair the ligament rather than the reconstruct. This is also come in a joint preservation era. So not the confusion is only in surgical procedure. Even non-surgical procedures also we have confusion which kind of medicine should be taken. Like this patient, 51-year-old, fed up of medicine, taking medicine, gastritis developed with NSAIDs. What else could we advise? So MRI has been done. There was no meniscus tear. The another patient, the renowned gynecologist from Bhavnagar, has been evaluated with MRI, failure of the conservative treatment, and there was a meniscal tear. So here, if there is a meniscal tear, we have to remove the mechanical problem and then we can inject, right? So what are the recommendations for non-operative, minimum invasive? Injection therapy definitely recommended. For first, we have to remove the torn meniscus. And then we can inject, viscosupplement. So which are the injection modalities? When there is a synovitis, we can inject steroid, hyaluronic acid that give cushion effect, PRP, stem cells. Newer concept is to combine hyaluronic acid with PRP. So, but the thing is, we have to respect this procedure. It should be done in OR. If infection develops, then patient is gone. The newer concept is to combine PRP and HA, as I trained with Professor Gobi in Italy. So what are orthobiologics? So they are really hype or hype. If we want to prevent replacement, we can repair or regenerate with PRP therapy. These are my own evolution for PRP therapy. Initially, when government practice, we used to take 150 ml of the blood and then we have to take that vacuums from the blood bank to the OR. Then development of the newer companies and only 30 ml of blood is required, 20-minute procedure. And the latest update after 2015, my training from Italy, only 10 minutes cost-effective treatment and only 8 ml of blood has been taken, 4 ml of PRP will receive. So this is the method how we can do PRP injections in knee joint. With my professor, I have hands-on. So literature also supports that if you combine PRP along with hyaluronic acid, that will give good effect. Like hyaluronic acid will give cushion effect and PRP will give regenerative effect. So newer babies in the market like Sahaj therapy, bone marrow aspiration, to take mesenchymal stem cells from the abdominal and then make the mesenchymal cells and inject it, but the long-term results are still awaited. So I personally don't recommend this kind of therapy. PRP therapy can also be used in other orthopedic problems like tennis elbow and tendinopathy. Some cartilage prevention, we all know that cartilage is a avascular structure. Once it is damaged, it can't regenerate. So what should be done? If we don't treat this cartilage damage, it ultimately leads to osteoarthritis. So according to the guidelines by Cartilage Society, if the small defect, we just do micropuncture. If the large defect, we have to choose some of the surgical intervention. So look at these patients. The age of the patient here, 25, 33, and even 16-year-old patient. So according to the need of the patient, like first patient is a laborer, he wants economic treatment. Second one is a teacher, reasonable cost. And third one is the son of sari businessman from Jodhpur. He wants best treatment for cartilage. So here we can use stem cells therapy. So these are the three different patients. The first patient, small defect. The another one is big defect. The third one is a very huge defect. What we can be do? So small defect, marrow stimulation by the microfracture. The second patient, there was a medium-sized defect. We take the non-weight-bearing area plugs and then we inject, we implant that plugs with specific instrumentation over the weight-bearing area. And this is the kind of solid fixation we will get, and patient can do whatever activity he is a teacher and easily climb 2 stairs daily. So this is the stable fixation we can get with this kind. This is the open kind of surgery. The third patient, young person, there is a cost was not limit. Patient offer for the best treatment. We have asked for the cell biologists. They came from the Pune. We have taken first surgery biopsy from the non-weight-bearing area. We have cultivated 48 million stem cells. So here, hyaline cartilage can be generated. This has been done around 10 years back in Sterling Hospital. The chondrocyte has been implanted. And this was the post-operative MRI evolution. This is the first longest evolution in India. Around 9 years follow-up MRI we have done. And that is showing the excellent healing. So look at the defect. And now there is a complete healing of the defect and hyaline cartilage is there. So here we can create normal anatomy. So if patient is asking in arthritis how we can use stem cells, no. Young patients, we can, with traumatic injury, we can use stem cells. So these are the results at around 9 years. Patient can do whatever he wants to do and stair climbing and easy running. So normal, patient takes a normal feeling over the knee joint. Right? When there is a varus alignment, mechanical issue, then we have to do osteotomy surgery along with the biological augmentation. These are the corrective osteotomy surgery done along with the arthroscopic biological stimulation. So this is a mechanical correction surgery. So what are the current guidelines apart from the surgical? As we know, the evolutions in the communication from this to this, and now very easy with mobile. So same way, if our mind know, then and then our eye can see. So we should know what is going around for the best treatment of the knee problems. So lifestyle modification, weight reduction, and non-contact physiotherapy braces are allowed for the osteoarthritis. Topical NSAID is strongly indicated. Injection steroids when synovitis, the best is PRP with hyaluronic acid. Conventional therapy like acupuncture, ultrasound, local, any electric therapy is not recommended. NSAIDs of any class not recommended with cardiovascular problem for long term. The newer things I will just mention, for painkiller, paracetamol and sometimes Tamapara combination is arrived. And the most important thing, nutraceuticals, chondroitin, glucosamine, collagen, these all are pharmaceutical driven, are not recommended by the International Society of Osteoarthritis Research. So we should keep this slide in mind. Non-weight bearing exercise, if patient of knee pain allowed to do walking for a long time, they will aggravate knee pain. So what are the advice for them? Static cycling and swimming is best for them. The knee braces, only knee cap will aggravate the knee joint pain. We should recommend unloading braces. The newer evolution in painkillers of NSAIDs, we all know the first generation, ibuprofen, there is no safety for gastritis and cardiovascular. The second generation, itracoxib, give safety to gastritis, but not for the cardiovascular. The newer polmacoxib is a kind of selective tissue COX inhibitor. They are safe for long-term use. They are so potent that only 2 milligram doses once a daily required. And long-term, they shows there is no cardiovascular side effects. But in Indian patients, still trials are awaited. For surgical, only wash of the knee joint by arthroscopy is not recommended. We should treat the underlying pathology, whatever is there, either meniscus or cartilage injury. So those patients who are awaited for the major surgery and a meniscus tear is not there on the MRI, to fill that patient gap, we should advise any injection therapy. So our experience so far, I have started my arthroscopy practice in government hospital 2009, then started private practice in arthroscopy before around 15 years, and that was 10 years I used to operate in various parts of the Saurashtra. Before 10 years we have established our own hospital. In 2015, the first lab of PRP in our own hospital, and after COVID, I stuck to my hospital and with various newer arthroscopic equipments. This is the PRP lab. These are the specific centrifuger for the PRP, not the blood bank centrifugers. They have designed specific PRP centrifuger. This is the technique how we do PRP injections. We have dedicated physiotherapy department which will go neuromuscular strengthening and neuromuscular balancing physiotherapy after this kind of surgeries. These are the initial my surgeries in government hospital. Apart from knee joint, we used to do shoulder and ankle and elbow arthroscopy. As I said, the base is in Bhavnagar. I am very much thankful to the Orthopedic Society of Bhavnagar, gave me support from very beginning of my practice. And some national and international presentation. We got first prize in Delhi regarding the PRP, our PRP research. We got best video presentation in Jaipur. Various presentation is various part of India. This is the first fellowship. I was the only person from India in 2009 to take the European fellowship in Portugal. This was a cartilage fellowship in 2015 from Indian Cartilage Society. I got training in sports injuries over there. In 2019, I got the Younger Investigator Award in Cancun, Mexico. And I was the only person from the Gujarat to get this scholarship. Global training around the world from Germany, Portugal, Chicago, Singapore, sports medicine from the Chicago. Some national presentation in Rajkot, Hyderabad regarding cartilage research, Ahmedabad, Baroda regarding PRP, and the concept of knee joint preservation was started from 2018. Before that, we also used to do meniscectomy or we just neglect, but then the meniscus repair concept is more. Some of the sports person has been treated, national judo player, basketball, long jump player, some sports traveling for medical tourism also, some football player from the Africa also treated with the, this kind of joint preservation surgery, teaching residents at KEM hospital regarding joint preservation surgery, teaching orthopedic surgeons in some of the workshops. So mind well, this is a team approach, not only the arthroscopic surgeon, it's the arthroscopic surgeon, orthopedics and sports physiotherapists. This is our international teamwork and this is our teamwork at our hospital. So we have started training newer orthopedic surgeon for arthroscopy at our own hospital, and I welcome all young residents and surgeons from not only from the orthopedic, even the physicians and physiotherapists and anatomy, people also can do research work. These are the, last year we presented 2-3 papers at our orthopedic conference regarding the research work in joint preservation. So I can summarize the take-home message. If patient come to your OPD with a sudden onset of knee pain, કે સાહેબ અહીંયા દુખે છે, right? If patients આખો હાથ મૂકીને કે દુખે છે, તો might be osteoarthritis. But if patient point with single finger, એક ફિંગરથી દેખાડો ક્યાં દુખે છે, and they have kind of pop or catching lock in, mind well, it most probably in a young patient it is a meniscus tear. Don't neglect, yes, still 2 minutes, right? Don't neglect it. Check with the weight-bearing epi X-ray. If there is no advanced arthritis and 50% of the joint space is preserved, always suspect meniscus tear. Don't delay to do MRI. And if you do MRI and there is a meniscus tear, then don't neglect it. Don't neglect it. I repeat, don't neglect it. Remember this slide. There is a rapid progression of arthritis. Within 9 months, patient has to do some major surgery if the meniscus is not repaired. And if repaired, we can decrease 132 times chances of future total knee replacement, right? And hope everyone over here and every one of our patients climb and achieves unchai in their later life. For that, don't want to replace your knee joint in early future, then preserve it and repair it. Thank you.
Thank you, Ujjwal Saib. Excellently summarized. Take-home message was very much clear.
Yes.
Any day, preserving the anatomy is far better than modifying the anatomy. So, excellent. We still have some time left. If there's any question from the audience, anybody?
Saib, Ravi Saib.
Thank you,
I
sir.
request chairpersons
So,
to...
I had one question that does alignment like varus valgus to any extent changes your indication while doing the meniscus root repair?
Yeah, if patient is complaining sudden onset of pain, previously that patient has no pain, then don't worry about the alignment because patient has bilateral deform alignment. If patient has no bilateral pain, then neglect it. If patient is sudden onset of pain, then only treat meniscus. No need to correct alignment. That's what I learned from my experience. I also corrected both, but those patients are not happy because one leg is straightened out and one leg is in varus deformity. So they are not happy patients.
Thank you.
Thank you.
Thank you. I request chairpersons to felicitate Dr. Deliwala.
Very much thankful to all the seniors of IMA Bhavnagar and colleagues give me this platform. Thank you. Thank you. Sir.
Thanks, Dr. Ujjwal, our chairpersons and Dr. Shah. It was a wonderful session. Moving ahead, we go to a completely non-academic session for a change. And I would like to quote Warren Buffett here. Those of you who do not know Warren Buffett are not allowed in the room. So he said, if you don't find a way to make money while you sleep, you will work till you die. So it is up to you to decide whether you want to make money while you sleep. And to throw light on this very interesting topic, we have two young gentlemen from Rajkot. And they run an agency called FinVitals. And recently they had done FinVestCon, which was attended by more than 250 delegates. And we could not make it. So we have called them here for all of you to take their expertise and make sure that you earn a lot while you sleep. This is especially useful for doctors because we have sleepless nights for our patients. To chair this session, let me call upon Dr. Jagdeep Kakadia, sir. He's an ophthalmologist. He's working in Bhavnagar since 1989, and his figures are alarming. You have to just, see the figures to make sure they are true. And he has a lot of innovations to his credit. He is an author too. Next up on stage is Dr. Kishore Solanki, sir, who is an orthopedic surgeon at Yash Hospital since 1993. His expertise lies in trauma surgery, and he has a special interest in looking for investment options. He was previously working as a full-time orthopedic surgeon at Surtee Hospital. So over to you, sirs, to take the session forward.
Thank you very much, ma'am. And this session is really going to be very interesting. For 1.5 days, we have been deliberating on health and the human health related issues. And today we are going to check about the health of our finance and our stability in the life. And we have an excellent opportunity to listen to the duo, Dr. Nishit Patel and Dr. Gaurav Patel. Both of them are neurologists from Rajkot, and not only neurologists, they both are financial wizards. To introduce Dr. Nishit Patel, he is a senior neurologist in Rajkot practicing for 16 years. And he was board first in standard 12th when he passed. And he embraces technology for positive impact in daily life. He is an active investor in equity, gold and debt for 8 years, and also a part-time trader. He completed courses in active investment, technical analysis, and future and options. He contributed articles in national finance journals, and he is also a state-level lecturer on basic investment. He pioneered the stock drop and pick and mutual fund selection, the SAFER criteria. He is an avid advocate for financial literacy amongst doctors, which is very, very important for all of us. He is co-founder of the FinVitals, a very interesting company which is dedicated for educating all of us for financial awareness for doctors. And he has organized numerous finances, investment and trading programs. And also to introduce Dr. Gaurav Dave. He's a director and senior consultant neurologist, again practicing for last 20 years in Rajkot, the founder member of Neurology Society of Rajkot, life member of IAN, that is Indian Association of Neurologists, API, and active corresponding member of the AAN. Pioneer in organized stroke care in Saurashtra. He organized neurology CMEs for Saurashtra and Kutch physicians. The principal investigator for international trial on multiple sclerosis, passionate about financial education amongst doctors. He, with Dr. Nishit Patel, is the co-founder of FinVitals, and he is the acclaimed organizer of very prestigious financial conferences, FinvestCon 1 and FinvestCon 2. So over to you, Dr. Nishit Patel. We all are eager to learn from you. Thank you.
Thank you, sir, for nice and exhaustive introduction. ભણવાનો ને ભણાવવાનો સમય પૂરો થઈ ગયો. તમને થશે હાસ, પણ હજી છાશ પીવાનો ટાઈમ નથી થયો. જ્યાં સુધી હરિહરનો સાદ ન પડે ને ત્યાં સુધી આપણે પાકશાસ્ત્રનો આનંદ નહીં લઈ શકીએ. એટલે ત્યાં સુધી થોડો અર્થશાસ્ત્રનો આનંદ લઈએ. અને આ જેમ નિધિબેને કીધું કે નોન એકેડેમિક ટોપિક છે, એટલે થોડુંક ગુજરાતી ભાષાનો પ્રયોગ, માતૃભાષાનો પ્રયોગ હું ચેરપર્સનની પરમિશન ને ઓડિયન્સની પરમિશનથી લઈશ. કારણ કે અમુક વસ્તુની મજા જે માતૃભાષામાં આવે ને એ સૂટ બૂટની ભાષામાં ન આવે. કારણ કે જભાલેંઘામાં જે મજા આવે ને સૂટ બૂટમાં નથી. અને જેમ કે ગાળો દેવાની મજા માતૃભાષામાં જ આવે. એટલે માફ કરજો થોડું ઓફ બીટ વાત થઈ. તો ફાઇનાન્શિયલ હેલ્થ ચેકઅપ, મેસઅપ એન્ડ કેચઅપ. At the outset, we are very much thankful to GIMACON organizing committee for inviting us to deliver this talk in front of this august audience, and moreover to consider the subject of finance in this state level conference, because nowadays it is need of an hour. Why education, financial education and awareness is very much important amongst doctors. The first and foremost thing is our professional learning usually starts late if we compare with the other professions like a CA or an engineer or even an architect. we usually start our practice late and we start earning after 30 years of age. And that is why our peak earning age comes after the 40 or 45 years. And we are at least 5 years late as compared to our peers, and that is why financial education awareness, saving and investment is very important for us. Because in finance, if you want full advantage of compounding, you have to start early. As long as જેટલું તમે વહેલું ચાલુ કરશો એટલું તમને ગ્રોથ અને કમ્પાઉન્ડિંગનો વધુ બેનિફિટ મળશે. સેકન્ડ થિંગ, યુવરાજ સિંહને ખબર છે કે ડૉક્ટર્સને છે ને ફાઇનાન્સની અવેરનેસની એજ્યુકેશનની બહુ જરૂર છે. ચલો સાંભળીએ શું કહે છે.
बल्ला नहीं चलेगा तो फिर जब तक बल्ला चल रहा है ठाट चल रहा है, जब बल्ला नहीं चलेगा तो फिर
એટલે આપણે ડૉક્ટર તરીકે જ્યાં સુધી આપણી ખુરશી ઉપર બેઠા છીએ ને ત્યાં સુધી જ આપણી ઇન્કમ છે. ધેટ ઇઝ ધ બિગેસ્ટ ડ્રોબેક ઓફ મેડિકલ પ્રોફેશન. તમે વેકેશન ઉપર જાઓ છો, અનફોર્ચ્યુનેટલી કોઈ મેડિકલ એવું બને છે કે તમારે 4-6 મહિનાની લીવ લેવી પડે છે, જેમ કે કોવિડ દરમિયાન ઓપીડી બંધ હતી, તો અવર ઇન્કમ બિકમ્સ ઝીરો. સો ઇટ ઇઝ વેરી ઇમ્પોર્ટન્ટ કે વી હેવ ટુ હેવ સમ another passive income which help us when we are not on the chair. Third thing is, doctors are soft target everywhere, right? આપણને ખબર જ છે કે બધા લોકોનો આપણે ન ઓલું હિટ મી ટાઈપનું છે, બધા લોકો આવીને આપણને હિટ કરી જાય. એટલે કારણ કે આપણી પાસે બહુ પૈસા છે, બધાને ખબર છે, પણ આપણી પાસે નોલેજ બહુ ઓછું છે, ખાસ કરીને ફાઇનાન્શિયલ નોલેજ. અને સેકન્ડ થિંગ કે નોલેજ હોય, પૈસા હોય, પણ એમ છતાં આપણી પાસે સમય નથી. બરાબર? એટલે એને કારણે શું થાય છે કે જેમ કે કોઈ આપણને મળી જાય, સપોઝ મને કોઈ નોન મેડિકલ વ્યક્તિ ક્યાંક જમણવારમાં તો પૂછશે કે સાહેબ મને હાથ પગમાં ખાલી ચડે છે, મારે દવા કઈ લેવી? એટલે વોટ આઈ વિલ ટેલ કે ભાઈ તમે કામ કરો, ક્લિનિકે આવો, આઈ વિલ ટેક યોર હિસ્ટ્રી, આઈ વિલ ડુ યોર એક્ઝામિનેશન એન્ડ ધેન આઈ વિલ એડવાઇઝ ધ મેડિસિન. આઈ વોન્ટ ટેલ હિમ કે ભાઈ ફલાણી કંપનીની ઢીકણી દવા છે ને બહુ સારી આવે, તું લઈ લે, રાઈટ? પણ આપણી સાથે એવું જ બને છે, ક્યારે કોઈ એજન્ટ છે, બેંકવાળા છે, કોઈ ફાઇનાન્શિયલ પ્રોડક્ટ વેચવાવાળી વ્યક્તિ છે, આપણી પાસે આવે કે સાહેબ ફલાણી ઢીકણી પૂંછડી પ્રોડક્ટ બહુ સારી છે, બહુ સારું રિટર્ન આવશે, તમે લઈ લો. બરાબર? એ આપણને પૂછતો નથી કે ભાઈ તમારું ફાઇનાન્શિયલ સ્ટેટસ શું છે, તમે કંઈ ઇન્વેસ્ટમેન્ટ કરેલું છે, નથી કરેલું, તમારા ફાઇનાન્શિયલ ગોલ શું છે. ડાયરેક્ટલી આપણને પ્રોડક્ટ વેચી આપે છે. ફાઇનાન્શિયલ પ્લાનિંગ યુઝ્યુઅલી જે છે એ પ્લાનથી શરૂ થવું જોઈએ, પછી પ્રોસેસ આવે અને પછી પ્રોડક્ટ આવે. જ્યારે આપણા કિસ્સામાં શું થાય છે, સૌથી પહેલાં પ્રોડક્ટ આવે છે. જરૂર હોય કે ન હોય, તમે પ્રોડક્ટ લઈ લો, પ્લાનનું જે હશે જોયું જ હશે. એટલે ધીઝ આર ધ 3 reasons કે ફાઇનાન્શિયલ એજ્યુકેશન એન્ડ અવેરનેસ ઇઝ વેરી ઇમ્પોર્ટન્ટ. એન્ડ બિકોઝ ઓફ ધીઝ 3 reasons our whole financial planning is messed up, right? એન્ડ મી એન્ડ ડૉક્ટર ગૌરવ દવે મારા સિનિયર ફ્રેન્ડ છે, મારા પછી એમનું જ ટોપિક લેવાના છે. વી આર ટ્રાઇંગ ટુ બીકમ એક્ટિવ ઇન ધીસ એરિયા ટુ ડૂ સમથિંગ ફોર ધ ડૉક્ટર્સ, બિકોઝ અમે બે મુંડાયેલા છીએ, એટલે બીજા ડૉક્ટર્સ ન મુંડાય એના માટે અમે સતત પ્રયત્નશીલ છીએ. અને વી હેવ અ ગ્રુપ નેમ્ડ એઝ અ ફિનવાઇટલ્સ. અમારું વોટ્સએપ ગ્રુપ છે, ટેલિગ્રામ ગ્રુપ છે, મોર દેન 460 પાર્ટિસિપન્ટ્સ છે. અને વી હેવ કન્ડક્ટેડ સો મેની કોન્ફરન્સીસ, ઓલમોસ્ટ 5 કોન્ફરન્સીસ ઓર આઈધર ઓનલાઈન ઓર ઓફલાઈન વિધિન અ સ્પાન ઓફ 14 months. And we have got a very good response from all across the Gujarat. And અહીંયા એક ચોખવટ કરી લઉં કે હમણાં મને એક ડૉક્ટર પૂછતા હતા કે તમે હવે પ્રેક્ટિસ કરો છો કે નહીં? એટલે મી એન્ડ ડૉક્ટર દવે બોથ આર પ્રાઇમરીલી ન્યુરોફિઝિશિયન. ભગવાનની દયાથી પ્રેક્ટિસ પણ ઠીકઠાક ચાલે છે. અને અમારો મેઇન એમ છે ઓપીડી અને ઇન્ડોર, ફૂલ ફ્લેજ અમારું ઇન્ડોર સેટઅપ છે. એટલે એવું ન માનતા કે ભાઈ અમે ફાઇનાન્સ જ કરીએ છીએ. ભાવનગરમાં બહુ સારા ન્યુરોલોજીસ્ટ છે, પણ કદાચ જરૂર પડે તો રાજકોટ રિફર કરી શકશો અમને. એવું ન માનતા કે શેર માર્કેટે અમારું કરી નાખ્યું છે. સો કમિંગ ટુ ધ મેઇન પાર્ટ, ધેટ ઇઝ ધ ફાઇનાન્શિયલ હેલ્થ. ડૉક્ટર તરીકે આપણે બધા હેલ્થ તરીકે સાથે ડાયરેક્ટલી સંકળાયેલા છે, ફિઝિકલ હેલ્થ, બટ ધીસ ઇઝ અબાઉટ ધ ફાઇનાન્શિયલ હેલ્થ. વી ઓલ નો ધેટ હેલ્થ ઇઝ વેલ્થ, બટ ટુ ધ કાઉન્ટર પાર્ટ ઓફ ધેટ, વેલ્થ ઇઝ ઓલ્સો વેલ્થ. વેલ્થને તો વેલ્થ તરીકે લેવી જ જોઈએ. સો ફાઇનાન્શિયલ હેલ્થ ઇઝ બેઝિકલી ગુડ ફાઇનાન્શિયલ હેબિટ્સ, ગુડ મની મેનેજમેન્ટ, પ્રુડન્ટ ફાઇનાન્શિયલ પ્લાનિંગ એન્ડ એબિલિટી ટુ અચીવ ફાઇનાન્શિયલ ગોલ્સ. આ બધી વસ્તુ હોય તો તમે ફાઇનાન્શિયલી હેલ્ધી કહેવાઓ. અને જો ફાઇનાન્શિયલી હેલ્ધી હો તો ધેર ઇઝ રિમૂવલ ઓફ ફાઇનાન્શિયલ સ્ટ્રેસ એઝ વેલ એઝ રિમૂવલ ઓફ ફાઇનાન્શિયલ ઇનસિક્યુરિટી. અને ફાઇનાન્શિયલ સ્ટ્રેસ અને ફાઇનાન્શિયલ ઇનસિક્યુરિટી આપણા બધામાં કેટલી છે આપણે બધા જાણીએ જ છીએ, બરાબર ને? એ ડિસ્કસ કરવાની જરૂર નથી. એટલે જો ફાઇનાન્શિયલ હેલ્થ હોય તો બંને વસ્તુમાંથી આપણે બચી શકીએ. ઇનસિક્યુરિટી તો એટલી હોય કે મારી ઓપીડી થોડાક ઓછી હોય ને તો ગૌરવભાઈને ફોન કરી દઉં કેવી સિઝન ચાલે છે. જાગનાથમાં 2-3 જણાને ત્યાં મારો સ્ટાફ મોકલી દઉં કે જોયા તો બહાર કેટલા ચપ્પલ સ્લીપર પડ્યા છે. એટલે આ ઇનસિક્યુરિટી ખૂબ છે ને, એ રિમૂવ કરવા માટે આપણે ફાઇનાન્શિયલ હેલ્થ અચીવ કરવાની છે. ઇફ ફાઇનાન્શિયલ હેલ્થ ઇઝ સો મચ ઇમ્પોર્ટન્ટ, વાય આર વી ઇગ્નોરિંગ ઇટ? ફર્સ્ટ થિંગ ઇઝ કલ્ચર એન્ડ ટ્રેડિશન. વેન એવર વી ડોક્ટર્સ મીટ ઇન એની કોન્ફરન્સ ઓર એની સોશિયલ ગેધરિંગ, આપણો ટોપિક ડિસ્કશનનો એક જ હોય, પેશન્ટ્સ પેશન્ટ્સ પેશન્ટ્સ. આ પેશન્ટ આમ હતું, આ પેશન્ટ આમ હતું, મેં હમણાં આ જોયું. વી નેવર ડિસ્કસ ફાઇનાન્શિયલ મેટર્સ અમંગ્સ અવર સેલ્ફ, રાઇટ? દેટ ઇઝ અવર કલ્ચર એન્ડ ટ્રેડિશન એન્ડ દેટ વી નીડ ટુ ચેન્જ. Second thing is lack of knowledge, understanding and awareness. Third is myths. Myths about having money. ઘણાને એમ થાય કે suppose someone financial planner comes, what we say, we become Paresh Rawal. इधर जहर खाने के भी पैसे नहीं है और तो फाइनेंशियल प्लानिंग की बात कर रहे हैं. And sometimes we become big B. आज मेरे पास बंगला है, गाड़ी है, नौकर है, चाकर है, मुझे फाइनेंशियल प्लानिंग की क्या ज़रूरत है, राइट? सो बोथ दिस थिंग्स आर रॉन्ग. वेदर यू आर हैव अ लेस मनी और वेदर यू आर हैव अ मोर मनी, फाइनेंशियल प्लानिंग इज इम्पोर्टન્ટ ફોર એવરીવન, રાઈટ? એન્ડ લાસ્ટ થિંગ ઇઝ ટાઈમ પોવર્ટી. આપણી પાસે સમય જ નથી. વી આર ટાઈમ પુઅર પીપલ. એકચ્યુઅલી ઇન 24/7 વી આર ઇન ધ ઇમરજન્સીઝ એન્ડ ઇન 24/7 વી આર પ્રિન્ટિંગ મની. વી આર મની પ્રિન્ટિંગ મશીન વિચ ઇઝ વર્કિંગ રાઉન્ડ ધ ક્લોક, રાઈટ? Because in scam 2003 recently Telgi said, though it is in an illegal way, कि पैसा कमाया नहीं बनाया जाता है. We all know that कि पैसा कमावा केम छे. We are money printing machine. We are earning money, earning money, earning money. પછી લોકરમાં મૂકી દઈએ, અહીંયા મૂકી દઈએ, ત્યાં મૂકી દઈએ, કોથળામાં સંતાડી દઈએ. પણ we don't know કે ભાઈ પૈસામાંથી બીજો પૈસો કેમ બનાવવો. And that we need to learn, right? પણ તમે કહી શકો કે મારી તો લાખોની પ્રેક્ટિસ છે, હું લીડિંગ ડૉક્ટર છું, મારી પાસે આટલી બધી ઇન્કમ છે, બેંક એકાઉન્ટમાં લાખો કરોડો રૂપિયા પડ્યા છે, મારે શું કામ કોઈ વસ્તુની જરૂર છે? વાય? ધીસ ઇઝ નોટ સફિશિયન્ટ. એનું રીઝન એક જ છે, ઇન્ફ્લેશન, રાઈટ? થિંગ્સ આર બિકમિંગ કોસ્ટલીયર એન્ડ કોસ્ટલીયર એવરી ડે એન્ડ ઇફ યુ ડોન્ટ ડુ એનીથિંગ વિથ યોર અર્ન્ડ મની, યોર મની ઇઝ ડેપ્રિસિએટિંગ 6 to 7% per year, right? Saving account gives you only 4% interest and your inflation is around 6 to 7%. That is the biggest reason that you should not only save, you should invest also. Saving is you are just making your money secure, while investing is you are making your money to grow. Now what are the parameters of financial health? These are the 6 parameters, right? We will discuss them one by one. First, coming to cash flow and budgeting. આપણે ભારત દેશના બજેટ વિશે ઘણી ચર્ચા કરીએ છીએ, પણ ઘરના બજેટ વિશે ભાગ્યે જ ચર્ચા કરતા હોઈએ. If you want to do proper financial planning, first thing is family cash flow statement. It is a detailed statement of income, expense and investments and whether we are generating surplus cash flows or not. આમ બહુ સિમ્પલ લાગે, પણ પ્રેક્ટિકલી મને નથી લાગતું કે હાર્ડલી લેસ દેન 1% ઓફ પીપલ આર એબલ ટુ ડુ ધીસ રેગ્યુલરલી એટ હોમ. બરોબર છે? ઘરનું બજેટ બનાવવું બહુ અઘરી વસ્તુ છે. If we see the cash flow statement, it is divided mainly into the 2 parts. One is cash inflow part, obviously the income part. આવક ને જાવક, તો આમાં આવકની વાત છે. Income from every source we need to cover in this, right? And other is the cash outflow statement. એટલે જાવકનો હિસાબ રાખવાનો છે. In cash outflow there are the 2 parts. One is the expenses and other is the investments. And expenses again can be regulatory expenses like taxes or insurance premium or EMI, and it can be living expenses, જે હાઉસહોલ્ડ ખર્ચા આપણે રેગ્યુલરલી થતા હોય છે, ફૂડનો ખર્ચો થાય, દૂધનો ખર્ચો થાય, બિલ ભરવાનો થાય, પેટ્રોલ ખર્ચો થાય, આ બધાનો આપણે હિસાબ લખવાનો છે. અને ધેર આર વોલન્ટરી એક્સપેન્સ ઓલ્સો, જેને લાઇફસ્ટાઇલ એક્સપેન્સ કહેવાય છે, કે ભાઈ તમે તમારી જે લાઇફસ્ટાઇલ પ્રમાણે વેકેશન લ્યો છો, તમે કોઈ શોપિંગ કરો છો, એ બધા જે એક્સપેન્સીસ આવે છે. એટલે આ બધાનો આપણે છે ને એક હિસાબ રાખવાનો છે. કેશ આઉટફ્લોમાં ઇન્વેસ્ટમેન્ટ્સનો પણ હિસાબ રાખવાનો છે. So ultimately, out from this cash inflow and outflow, we need to decide of an entire family what is our net cash flow. Ideally, the net cash flow should be positive, right? And at least there should be 25% of the difference between your income and expenses. Expenses should not be more than 75% of your pre-tax income. And in that remaining 25%, આપણે emergency fund રાખવાનું છે અને investments પણ કરવાના છે. And investments should be sufficient to achieve your financial goals. ઇમરજન્સી ફંડ કેટલું હોવું જોઈએ? લગભગ તમારા 6 મહિનાના ખર્ચા જેટલું ઇમરજન્સી ફંડ હોવું જોઈએ. એમાંથી 50% છે તમારે સેવિંગ એકાઉન્ટમાં રાખવું જોઈએ, 50% લિક્વિડ ફંડમાં રાખવું જોઈએ. ઇમરજન્સી ફંડનો બહુ સારો અવેરનેસ કોવિડ દરમિયાન આવ્યું હતું કે જ્યારે લોકડાઉન થઈ ગયું હતું ત્યારે, કારણ કે વી વર નોટ એબલ ટુ અર્ન. કોમન મેસઅપ કે આપણે બજેટ નથી રાખતા, આપણી બેલેન્સ શીટ પુઅર હોય છે અને ઇમરજન્સી ફંડ ઘણીવાર પ્રોપરલી નથી રાખતા. અધર મેસઅપ ઇઝ અ નેગેટિવ કેશ ફ્લો. આપણે એવું જોઈએ કે ભાઈ ઘણા બધો એમાઉન્ટ છે ને આપણો ઈએમઆઈમાં જતો રહેતો હોય છે, ઘણી બધી વસ્તુ છે ને અનનેસેસરી એક્સપેન્સીસ થઈ જતા હોય છે, એટલે આવક ઓછી થાય અને જાવક વધી જાય. સાદી ભાષામાં કહીએ તો આમદની અઠણની ખર્ચા રૂપિયા, રાઈટ. એન્ડ અધર થિંગ ઇઝ કે ઘણી વખત આપણી ઈએમઆઈ એટલી બધી વધારે હોય કે મોસ્ટ ઓફ આપણી ઇન્કમ હોય ઈએમઆઈમાં જતી રહી. એટલે લોન લેતા પહેલાં આપણે ધ્યાન રાખવું જોઈએ કે 25%થી વધારે આપણી પ્રી ટેક્સ ઇન્કમ ઈએમઆઈમાં ન જવી જોઈએ. અને નાના નાના ખર્ચા ઉપર લગામ રાખવી જોઈએ. ખાસ કરીને ઓનલાઈન શોપિંગના જમાનામાં થોડું કરીને ક્યાં ખર્ચો જતો રહે છે ખ્યાલ નથી આવતો. એન્ડ બચત એ બીજો ભાઈ છે. ટ્રાય ટુ સેવ એટલીસ્ટ 25% ફ્રોમ યોર પ્રી ટેક્સ ઇન્કમ. ધેટ ઇઝ વેરી ઇમ્પોર્ટન્ટ. એન્ડ આપણે એમ કહીએ કે ભાઈ શું કરીએ, બચતું જ નથી, બિકોઝ વી હેવ અ સ્પેન્ડિંગ બજેટ. આપણી ઇન્કમ આવે એમાંથી ખર્ચા કરી નાખીએ, પછી કાંઈ વધે તો સેવિંગ કરવા જઈએ. પણ ધીસ ઇઝ નોટ ધ રાઇટ થિંગ. રાઇટ થિંગ ઇઝ ઇન્કમમાંથી પહેલાં તમારો સેવિંગ જેટલો પાર્ટ હોય 25% એને સેપરેટ કરી નાખો અને પછી કાંઈ વધે તો એમાંથી ખર્ચા કરો, રાઈટ. સો વી હેવ ટુ કન્વર્ટ અવર સેલ્ફ ફ્રોમ સ્પેન્ડિંગ બજેટ ટુ સેવિંગ બજેટ. ધેન ટેક્સ પ્લાનિંગ. તમને એમ થાય કે લે ટેક્સ તો કાંઈ ભરવાની વસ્તુ હોતી હશે. મોસ્ટ ઓફ ધ ટાઈમ વી ગો ફોર ટેક્સ ઇવેઝન. આપણે ઇલીગલ રસ્તા કરીએ ટેક્સ ન ભરવા માટે. પણ આઈડિયલ થિંગ ઇઝ ટેક્સ એવોઇડન્સ. લીગલ જે ગવર્મેન્ટે આપણને પ્રોવિઝન્સ આપ્યા છે ટેક્સ બચાવવા માટેના, એ પ્રોવિઝન્સનો આપણે યુઝ કરવો જોઈએ અને ટેક્સ બચાવી શકાય. સારો એવો ટેક્સ બચી શકે જો આપણે પ્રોપર પ્લાનિંગ કરીએ તો. મોસ્ટ ઓફ ધ ટાઈમ શું થાય કે આપણે માર્ચ એન્ડમાં દોડાદોડી કરીએ ટેક્સ બચાવવા માટે અને અલગ અલગ પ્રોડક્ટ લઈ લઈએ. પણ આઈડિયલી ટેક્સ પ્લાનિંગનો પ્રોપર ટાઈમ છે એટ ધ બિગિનિંગ ઓફ ધ ફાઇનાન્શિયલ યર, ધેટ ઇઝ ઇન ધ એપ્રિલ મંથ ઇટ સેલ્ફ. જો પ્રોપર પ્લાનિંગ ટેક્સનું કરીએ તો ઘણો બધો બેનિફિટ થઈ શકે. એન્ડ ફોર ધેટ વી નીડ ટુ લર્ન વેરિયસ ટાઈપ ઓફ ઇન્કમ ટેક્સ ડિડક્શન્સ. વી નીડ ટુ હેવ બેનિફિટ ઓફ હિન્દુ અનડિવાઇડેડ ફેમિલી. વી નીડ ટુ હેવ બેનિફિટ ઓફ નેશનલ પેન્શન સ્કીમ ઓલ્સો. એન્ડ વી હેવ ટુ ડુ ઇન્વેસ્ટમેન્ટ ઇન ધ ટેક્સ સેવિંગ growing assets like PPF or in a ELSS or a Sukanya Samruddhi Yojana. We should not take expenses as a deduction in the tax, but we should take investments as a tax saving instruments. આ મોટો મેસઅપ છે. માર્ચમાં આપણને સીએ કે એકાઉન્ટન્ટ ફોન કરશે કે સાહેબ બહુ ઇન્કમ વધી ગઈ છે, કંઈક એકાદી ગાડી લઈ લ્યો એટલે ડેપ્રિસિએશનનો લાભ બને અને ટેક્સ બચી શકાય. એટલે આપણે કોઈ મર્સિડીઝ ને BMW વસાવી લઈએ અને ધેટ ટુ ઓલ્સો ઓન EMI. Basically, that is the biggest mess up. If you want to buy a luxury car, you have a passion, you have a money, you can buy it, right? But don't buy it for the tax saving. You buy it, pays EMI, not only maintenance, આનો એટલો બધો વધારે છે. આ બધા છે ને ઓલા કહેવાય ને ધોળા હાથી જેવા હોય કે એનો મેન્ટેનન્સ જ એટલો બધો વધારે હોય. એને રસ્તા ઉપર ચલાવશો ક્યાં કોઈક ઠોકી જશે તો વળી રિપેર કરાવવી પડશે. પાર્કિંગની જગ્યા નથી હોતી. દેર આર સો મેની ઇસ્યુઝ, રાઈટ. અને ગમે એવી સ્પીડે જતી હોય, હવે તમારી આગળ બળદગાડું જતું હોય તો સ્પીડનું શું કામ છે? એટલે સો ડોન્ટ ટેક સચ ટાઈપ ઓફ પ્રેક્ટિસીસ. નાવ કમિંગ ટુ ઇન્સ્યોરન્સ પ્લાનિંગ. વીમા આપણા બધા પાસે બહુ બધા હોય છે. લાઈફ ઇન્સ્યોરન્સ, હેલ્થ ઇન્સ્યોરન્સ, ડિસેબિલિટી, પ્રોપર્ટી, ઓટો એન્ડ પ્રોફેશનલ. ધીઝ આર ધ ઇન્સ્યોરન્સ વી નીડ ટુ ટેક, રાઈટ. બટ વોટ હેપન્સ મેની ટાઈમ્સ વી ઇગ્નોર લાઈફ ઇન્સ્યોરન્સ. કે ભાઈ મારી પાસે આટલી ઇન્કમ છે, લોકરમાં આટલા રૂપિયા પડ્યા છે, મારે જીવન વીમાની શું જરૂર છે? ઓર સમટાઈમ્સ વી ટેક સો મેની ઇન્સ્યોરન્સીસ. HDFC વાળા, LIC વાળા, માસાના દીકરા, કાકાના દીકરા, ફલાણા ઢોકણા, G સિરીઝવાળા બધાએ તમને ઇન્સ્યોરન્સ પકડાવી જશે. એટલે તમારી પાસે એટલા બધા ઇન્સ્યોરન્સ થઈ જશે કે તમારો જરૂર કરતાં વધુ કવર થઈ જશે. તમને ખુદને ખબર નહીં કે મારી પાસે કેટલી પોલિસી છે, અથવા ઘણીવાર ઊંધું કરીએ કે ભાઈ આનો પ્રીમિયમ બહુ વધારે છે, આપણે આટલો બધો ઇન્સ્યોરન્સ નથી લેવો. આઈડિયલી તમારો જે એન્યુઅલ એક્સપેન્સ હોય, જે આપણે કેશ ફ્લો અને બજેટિંગમાં ડિસાઇડ કર્યો છે, એનાથી 20 ગણા જેટલો પ્રીમિયમ, એના 20 ગણા જેટલો કવર મળે એટલો આપણે ઇન્સ્યોરન્સ લેવો જોઈએ. અને ઇટ શુડ બી પ્યોર ટર્મ ઇન્સ્યોરન્સ. વી શુડ નોટ ટેક એન્ડોમેન્ટ પોલિસી, વી શુડ નોટ ટેક યુલિપ, કારણ કે આ પોતે જ મેસ્ડ અપ પ્રોડક્ટ છે. જાજા રસોઈયા રસોઈ બગાડે એવી ગુજરાતીમાં કહેવત છે. આમાં એને બધી વસ્તુ મિક્સ કરી દીધી છે. ડેથ બેનિફિટ છે, મેચ્યોરિટી બેનિફિટ છે, ટેક્સ બેનિફિટ છે, સરેન્ડર વેલ્યુ છે. એટલે પછી ન ઘરના ન ઘાટના, તમને પૂરો ઇન્સ્યોરન્સ નથી મળતો, તમને પૂરું ઇન્વેસ્ટમેન્ટ નથી મળતું. એ જ રીતે યુલિપ છે, માર્કેટ લિંક પ્રોડક્ટ છે, પણ એના એક્સપેન્સીસ એટલા બધા વધારે હોય છે કે તમને ન ઇન્વેસ્ટમેન્ટ મળે છે, ન ઇન્સ્યોરન્સ મળે છે. હવે એમ થાય કે ભાઈ નક્કી કેમ કરવું કે આ યુલિપ છે કે એટલે યુલિપની તો તોય ખ્યાલ આવી જાય, પણ ખબર કેમ પડે કે ભાઈ એન્ડોમેન્ટ પોલિસી છે? તો જ્યારે તમને ઇન્સ્યોરન્સમાં એજન્ટ એમ કહે કે તમને તમારા પૈસા પાછા મળશે, એનો મતલબ કે એન્ડોમેન્ટ પોલિસી છે. ઇન્સ્યોરન્સ હોય, પ્યોર ટર્મ ઇન્સ્યોરન્સ હોય, તો તમને તમારા મૃત્યુ પછી જ તમારી નેક્સ્ટ જનરેશનને પૈસા મળે, તમને તમારા પૈસા ક્યારેય પાછા ન મળે. પણ જો એન્ડોમેન્ટ પોલિસી હોય તો તમને તમારી હયાતીમાં પૈસા પાછા મળે. અને અમે એક સૂત્ર બનાવ્યું છે, ઇફ ધેર ઇઝ અ મની બેક પોલિસી, સો યોર બેક ટુ ઇટ. રાઈટ. લાસ્ટલી હેલ્થ ઇન્સ્યોરન્સ. આપણને એમ થાય કે આપણે ડૉક્ટર તરીકે આટલા લોકોને જાણીએ છીએ, આપણે હેલ્થ ઇન્સ્યોરન્સની શું જરૂર છે? રાઈટ. ગમે તે લોકો મારી ટ્રીટમેન્ટ તો ફ્રીમાં કરી આપશે. પણ નાવ ડેઝ it is an era of expanding medical fields. There are lot of new innovations are coming up, new type of treatments are coming up, new type of diseases are also coming up, right? Lung transplant, liver transplant. So if we need to take benefit of that, we have to have a medical insurance, because ગમે એવો પૈસાદાર માણસ હોય, જો એને ઇમરજન્સીમાં ક્રિટિકલ ઇલનેસમાં કેઝ્યુઅલ્ટીમાં એડમિટ થવું પડે અને 2-3 મહિના જો હોસ્પિટલનું રોકાણ થાય તો છેલ્લે એની હાલત આવી થઈ જાય. Health insurance is wealth insurance. It protects your wealth in times of medical emergency. So don't ignore health insurance. Now next part is investment planning, and for that I invite my colleague Dr. Gaurav Dave.
Welcome, Dr. Gaurav.
Now we just going to discuss a bit about investment planning. I think the word investment planning includes the word planning, and that means we have to plan first and then execute. And the investment planning we have to done from whatever that 25% we have saved. And if you say just tell me a single word about investment, I will just advise you to remember this word of Brian Tracy. A goal without a plan is only a dream. So if you have a goal that your children will have a good education in overseas country, if you want to have a very relish retired life, you want to purchase a Mercedes car or whatever expensive car, you must plan. Otherwise it is going to remain a dream only. And what we usually do is, we usually invest, just as Nishit said, to save a tax. LIC people will come and tell you, આમાં ઇન્વેસ્ટ કરી લો, ટેક્સ બચશે, ગાડી લઈ લો, ટેક્સ બચશે. Because my friend has taken a shares or give me a tip of share કે ભાઈ જેટ એરવેઝના તમે શેર લઈ લો, મેં લઈ લીધા અને નેક્સ્ટ વન જેટ એરવેઝ જ બંધ પડી ગઈ. અને because someone is advisor, they will tell you to buy their whatever mutual fund product or LIC product, we just used to buy it. That is not an investment. Because we just blindly pump money in various assets without realizing that they are not going to help our goals. If I have to beat inflation, if I have to send my son after 10 years, how a LIC policy is going to help me out? So for that we need a goal-based financial planning, which is a key to achieve a personal financial success, and we must maintain a discipline. It is not a single time decision or a single time process. And how we invest? We have to invest across various assets, and if we classify them, there are only 4 major assets in which we have to invest. Gold, it is easily remembered with the mnemonic GRED, G-R-E-D, gold, real estate, equity and debt investment. And it gives us a good diversification. So if you invest across all the assets with unforeseen circumstances, maybe some global, maybe some personal, your investment will remain safe. So let us talk with the debt investment first. These are the various products in which we can invest, like FD, bonds, PPF, SSY, Sukanya, Senior Citizen Savings Scheme, Post Office schemes, and debt mutual funds. I think the FDs are nowadays not a very preferred mode of investment because of the low return it generates. The PPF and Sukanya Samruddhi do have some tax benefit, but do remember they have a very defined cap. So in PPF and even NPS and maybe in SSY, you have only a sum of 1.5 lakh which can you invest. You cannot invest more than that. So for that, either you have to go for debt mutual fund or any other such schemes. Please remember that the return of any debt product will depend on market interest rate. So they are never going to beat the inflation. But here our main concern is safety, not the return. So when we start with a safety, with a very good background, with a very solid platform, probably whatever the building you build over it, it is going to sustain the different kind of tides. Now comes the assets for protection, and I think India is a country of gold lovers. Why gold is so much popular? Because it protects us during the various fluctuations. તમે જો આ ગ્રાફ જો તો નીચેનો બ્લુ ગ્રાફ છે એ ઇક્વિટીનો છે કે સ્ટોક માર્કેટનો છે, યલો છે એ ગોલ્ડનો છે. નોર્મલી ગોલ્ડના રિટર્ન્સ એટલા બધા ન હોય, પણ ઇફ યુ સી 2020 એપ્રિલ જ્યારે કોવિડ હતું, when the equity down tanked, the gold has went up. એટલે જો ત્યારે કોઈ તમારો ફાઇનાન્શિયલ ગોલ એવો હોય, મે બી કોઈ ડૉક્ટરે મેડિકલમાં એડમિશન લીધું છે કે તમારે ત્યારે એને પૈસા આપવાની જરૂર નહીં, તમે ખાલી જો ઇક્વિટીમાં ઇન્વેસ્ટ કરેલું હોય તો એટ ધેટ ટાઈમ ઇટ વિલ બી વેરી ડિફિકલ્ટ ફોર યુ to manage that particular goal. In those case, gold is going to help you to deal with your goal. So gold આપણે always as a hedge તરીકે invest કરવાનું છે to protect us in various emergencies. It is internationally accepted. It helps us in crisis. It is a very good hedge. Again, the post-tax returns hardly beat inflation, પણ અહીંયા purpose એક જ છે કે ગમે ત્યારે emergency થાય ત્યારે gold use કરવાનું છે, અને we can use invest in gold around 10% of our portfolio. So if my portfolio or my investment say around 1 crore નું છે, તો I have to invest only 10 lakh into gold. આપણે અગેન નહીતર ઘણીવાર લોકો 20 લાખ 25 લાખ 50 લાખ ગોલ્ડમાં ઇન્વેસ્ટ કરતા હોય છે. Again, jewelry is not a good option as an investment in gold. It is an investment of love. You can give to your wife. But for investment, best is SGB, which is offer you lots of good things, digital. They will provide you 2.5% of simple interest. And additionally, if you keep it for 8 years, there is no capital gain. So again, you are saving on tax. So I think the simple fund is gold investment in nowadays is invest in SGB. There are only two assets which beats inflation, but important word is in long term. That is real estate, and second is equity. So whenever you think of investment in real estate or maybe in equity, you must be very clear in your mind that I am going to invest here for minimum 7 years, 10 years, 15 years. It should not be 1 year, 2 year or 3 year. What is real estate investment? It is a purchasing any piece of land, structure, infrastructure or any other tangible asset. They are often immobile, yet transferable to generate income from it. And do remember that your home and your hospital is not a real estate investment. Hospital is a place from where you are going to generate your income. Home is a place for which you are in fact earning, and whatever earning you are having, you are going to invest to generate income from it. So home and business place we are not considered as a real estate investment. So these are the various classes of real estate investment: residential, commercial, land, industrial. I think most of doctors are very well versed in the real estate investment, and they do agree that either nowadays a commercial place real estate investment or an investment in land, these are the one probably which going to beat the inflation over a long period of time. There are certain limitations of real estate investment. Number one is the big ticket size, because you need to pay big amount upfront. You need to check the legalities, records and titles, maintenance. The liquidity is a major issue, because if you have invested today and you say want it after 10 years, you really don't know whether the area has been developed or not, what are the buyers at that time. Again, the issues of land grabbing And the most important issue which we are probably not looking at is the next generation interest. અત્યારે કોઈ છોકરાઓને ઇન્ડિયામાં તો રહેવું જ નથી. Everyone wants to go out, કે મારે બહાર જ જવું છે, US, Canada. Now if you have piles of real estate and the kids are going to study there and probably going to settle there, who is going to look after that assets? So whenever we keep or make a decision of any real estate investment, please also ask your children, if they are elder, કે બેટા તું આને મેનેજ તો કરવાનો છો કે નથી કરવાનો. We had seen the instances કે ઘણીવાર પછી આમાં ઘણા બધા ઇશ્યુ થાય છે. Now comes the equity, the blue-eyed boy. અત્યારે બધે આની જ ચર્ચા ચાલે છે. Now India ranks 5th in the market capitalization globally, and it has been said that by 2030 we are going to surpass Japan, become the third global leader in market capitalization. And if you see the graph, this one? Okay, okay. Shortcut. It's a light shade. Okay. So this is the just graph on Nifty 50, which is the main benchmark of Indian stock market. From in year 2000, it was around 1,990, and now it has reached almost 20,000. So in this 23 years, it gave a compounded annualized growth rate of around 14%. And we know that now the inflation is around 6 to 7%. So how beautifully it beats inflation over a long term. So equity market in India, we have listed and unlisted companies. Listed companies are listed on BSE and NSE, and we have more than almost 5,000 companies. And these are the various categories across which usually the equity investment is there, whether it's stock or in mutual fund, whether it's a large cap, mid cap, small cap, or a micro cap. And most of medical professionals invest either only in stocks, only in mutual fund, or some may be doing both stocks and mutual fund. But whatever way you have been doing investment, which is a long-term process, you invest in systemic investment plan or SIP, or do it every month, rather than investing lump sum or waiting for a particular level કે હવે આ માર્કેટ નીચે જશે તો લેશું કે ઉપર જગ્યું છે નથી લેવું. You just invest whatever proportion of your money every monthly to get a 2P cost averaging. The biggest mess up of again the stock lovers, what we have seen is there are too many stocks in the portfolio, because they have been seeing too many channels, too many WhatsApp groups, too many Telegram groups, and there are lots of tips, so they are just buying without realizing. So ideally, if you see the graph, after almost 20 or 25 stocks, the risk of your portfolio is not going to decrease. So it is always better if you are doing only stock SIP, keep your long-term stock numbers somewhere between 15 to 20, not more than that. Same way, the mutual fund world is very complex, very big, more than 44 AMCs, more than 900 schemes. And it seems very complex to us, but I think we just need to make it very simple and invest in, say, only mainly 4 categories: large cap mutual fund, flexi cap, mid cap, small cap, and if you want a little conservative, maybe an aggressive hybrid or balanced advantage funds, and keep 2 or 3 schemes across, say, every mutual fund categories. So again, at the most 10 to 12 mutual funds. I think there are investors who had more than 30, 40 various schemes. એમાં તો ખાલી નામ રૂપ જુજવા અંતે એમનું એક એના જેવું જ હોય છે. અમુકના નામ બદલા હોય પણ અંદરના સ્ટોક સરખા હોય, એની સ્કીમ સરખી હોય. આપણને ખબર હોવી જોઈએ કે કોઈ આપણને કહે છે કે આમાં લો તો એને વી હેવ ટુ સે કે ઓકે આઈ હેવ દેટ લાર્જ કેપ મ્યુચ્યુઅલ ફંડ ઓનલી, યુ સજેસ્ટ મી સમથિંગ એલ્સ. અને better to invest in direct plans because they have a lower expense ratio. Always invest in growth option and increase your investment every year around 8 to 10%. So I think this is the most simplest way to invest in equity. Obviously, equity investment is also not without risk. The biggest risk is the scams. I think we have been hearing since many years that scams to bahut thai chhe. So we have Satyam scam, we have a Arshad Mehta scam, we have a Ketan Parekh scams. Second thing is volatility. Even government change થાય, budget આવવાનું હોય, macroeconomic issues થાય, the equity market will react to it. But we understand that equity has this disadvantage. So that's the reason we have been investing it for 7 years, 8 years, 10 years, and every monthly and not in lump sum. And nowadays in this technology-driven era, the biggest risk is I myself, because I take decision based on what I receive from various tips, and I just forget my whatever the investment planning I have decided. So please remember, your portfolio needs GPS. G means growth, which is by equity and real estate. So those, the youngsters in the group say, if you are 40 years of age, the equity proportion, equity and real estate proportion should be 100 minus your age. That means 60% you can invest if you have 1 lakh rupees, say 30,000 in real estate and 30,000 in equity. Same way, gold is 10%. So out of that 1 lakh, 10,000 in gold, and debt should be your age minus 10. That means around 30%. So 30% real estate, 30% equity, 30% debt, and 10% in its gold. This is the simplest one. If you can do this, probably you don't have much issues, and just continue doing this. Never neglect debt. I think many a time the euphoria of equity has been so much, the euphoria of real estate is so much, people don't invest in PPF. So this is the big mess up, that we have a over concentration in real estate and gold. We have a haphazard or ad hoc investment. કોઈ કીધું કે આ પ્લોટ સારો છે લઈ લો, આ ફ્લેટ નવા બને છે સારા છે લઈ લો, જરૂર છે કે નહીં પૂછ્યા વગર આપણે લઈ લઈએ છીએ, and then your whole investment plan has been just deranged. And we don't keep any goal based planning and investment. And આ બહુ ટિપિકલ છે કે we keep investing in growth assets for short term. આજે કોઈ સ્ટોક લીધો કે આજે કોઈ મ્યુચ્યુઅલ ફંડ લીધું ને જેવું બજાર પેલું છે તો 6 મહિનામાં કેવું વેચી નાખીશ. I think whenever you invest it, you must understand કે અમારે 6-7 વર્ષ નથી કાઢવાનું, તો જ તમે એમાં રહી શકશો. અને એફડી આપણે 6-6, 7-7 વર્ષની કરીએ. રિટાયરમેન્ટ પ્લાનિંગ, I think as Nishish has said, ડૉક્ટરને રિટાયર કોઈ દી થાય? આપણા મનમાં તો એવું છે કે આપણે તો છેક સુધી કરવાનું છે, એટલે ડૉક્ટર કે ક્યારે રિટાયર થાય છે? પહેલાં ઓલ્ડ થાય, પછી ટાયર્ડ થાય, પછી છેલ્લે રિટાયર થાય. ને જ્યારે રિટાયર થાય આ રીતે કરેલો કે આખી જિંદગી આપણે પેશન્ટ જ જોઈએ ને કંઈ ઇન્વેસ્ટમેન્ટનું વિચાર્યું જ નહીં, ત્યારે વી ઓનલી ધીસ ટુ થિંગ્સ, પીપીએફ અને એફડી જ આપણી પાસે હોય. એટલે એટ ધેટ ટાઈમ ઇટ ઇઝ ડિફિકલ્ટ ટુ બીટ ધ ઇન્ફ્લેશન. આપણે શું કરવા માટે રિટાયરમેન્ટ પ્લાનિંગનું વિચારવાનું છે? Because we have only one pillar of retirement stability. I am a doggy versus social security, and again I am trying to tell here everyone should have those both the scheme of social security and national social security schemes of IMA. I have taken, before I have started my private practice since last 20 years. At least આપણા IMA આપણા માટે આટલું કરે છે તો એ લેવી જોઈએ. We don't have any pension schemes from government. So whatever we have to rely for our retirement is through our investment only. And as Nishish said that our age for professional earning starts little later, set around age 30, 35. We have to provide more retirement amount for our financial planning, because it is a little stiff uprise if you see. Why? The reason life expectancy has been increasing. The average life is now more than 80 years. There is increasing cost of healthcare. I think you all must be experiencing કે અત્યારે જે ઘરડા લોકો છે જેના sons, daughters બધા US છે, what is the cost of caretaker? They have to pay every year. As a neurologist, we have been seeing a lots of patients of dementia, Parkinsonism, which need a lots of personalized and nursing care. So the amount of that cost is unimaginable. You need a financial independence at your later life. You have certain aspirations કે મારે ચાલો આ સ્કેન્ડિનેવિયન કન્ટ્રીમાં જો ફરવા જવાનું છે, અહીંયા જવાનું છે. So that for that you require money. You need to give a good inheritance to your future generations, and you want to contribute to your family, and at least want કે ઓકે મારે છોકરાઓ પાસેથી પૈસા નથી લેવા. For that you need a retirement planning. And these are the three ekas of retirement planning: PPF, NPS, and equity mutual funds. So I think if you start at the age of 35, age of 40, and say give a dedicated 20-25,000 per month, your retirement corpus will be like anything. And this is a very good site of omnicalculator.com, from where you can decide how much exact amount of retirement you will require. So you need to install in that what is your current age, what is your current monthly expense, till what year, say 20 years, 25 years, 10 years I am going to work, and how many years I have to live as a retired fellow without any active income. And if you put all these things, it will show you how much amount you need to save today to go get that figure. લાસ્ટ ઇઝ ધ એસ્ટેટ પ્લાનિંગ. વિલની વાત આવે એટલે આપણો વિલ પાવર જ ઢીલો થઈ જાય. આપણને એમ થશે કે હવે હું જો વિલ બનાવીશ ને તો કાલે જ મરી જઈશ. યમરાજા પાડો લઈને આવી ગયા છે મારા ઘરે. પણ વી શુડ નોટ ડુ ધીસ. Okay, will is required first to protect the asset, to secure our beneficiaries, save time and money of them. We should avoid family disputes and it can reduce taxes. And our biggest mess up છે કે there is આપણે ક્યારે will બનાવતા નથી. There is not written information of our investment at any place at our home. And third, in the most neglected part is we are not informing spouse or our adult daughters or sons about all our insurance and investments. I think in Rajkot we have quite a few instances where the doctors have suddenly expired and their family members are not knowing about their investment, and whatever આખી કાળી મજૂરી કરીને જેટલા પૈસા હતા is some other fellows will take out. So it is my humble request to everyone, just put down in simple notebook what are your investments, who is your advisors, what are your insurance policies. In fact, credit card માં બી ઘણીવાર તમને ઘણા બધા insurances available થતા હોય છે. At least they can have the benefit of everything. To sum up, we have to build a wealth pyramid. So in startup phase, as Nishit said, we have to do a cash flow budgeting, tax planning, building a safety net by various debt options. During peak earning years where we accumulate our wealth, we have to just do a proper investment, and cooling off period, we preserve our wealth. Do not take any debt after the age of 50. So we have to manage both the phases of wealth accumulation, then manage and then protect and distribute. So this is the last slide. So we have to make a positive cash flow, keep 6 times of your emergency fund, 25% savings is always first and then comes the expense. Tax planning should be done in April month of every financial year and take advantage of all tax saving investments. Please do not take any money back policies as insurance. Take adequate life, health and vehicle insurance. Do a goal-based investment by GRADE method. Start your retirement plan, start investing early in PPS, NPS, equity mutual fund and build a good corpus, and do a proper estate planning. તો આમ જુઓ તો ફાઇનાન્સના દરિયામાં છે ને કે જહાજ તો આપણે જ ચલાવવાનું છે. ખલાસીઓ તમે ભલે ગમે એટલા રાખો, પણ નાખુદા તમારે જ રહેવાનું છે અને સુકાન પણ તમારે જ સંભાળવાનું છે. આઈ થિંક ઇફ યુ આર learned better, probably we can able to tell our money to work better for us as well as our future generation. Thank you.
Thank you. Thank you, Dr. Nishit and Dr. Gaurav, for enlightening all of us on a very important aspect. If there are any questions from the audience before we make the chairman's remark. So before we conclude the session, સાહેબ મારો એક એક્સપિરિયન્સ આપને શેર કરીશ. I started my private practice in 1988 in Bhavnagar. Somehow I have observed કે મોતિયાનો ચાર્જ, એક વાર જમીનનો ચાર્જ અને એક તોલો ગોલ્ડનો ચાર્જ એ કોન્સ્ટન્ટ 1988થી અત્યાર સુધી આમ નામ ચાલ્યો આવ્યો છે. ધ સેમ થિંગ. ત્યારે અમે 2000 રૂપિયા લેતા હતા, 2000 રૂપિયા વાર વિજયરાજનગરમાં જગ્યામાં આવતી હતી અને લગભગ 10 મોતિયા ઉતારો એટલે 1 વીઘાનો ફાર્મિંગ લેન્ડ આવતી હતી. સો ધ લેન્ડ, ગોલ્ડ and our professional fees has more or less remained the same throughout. So if somebody has invested systematically, like I used to invest કે રોજના 10 મોતિયા કરીએ તો 6 મોતિયા છે એ આમાં જાય છે. સિસ્ટમેટિકલી જો ઇન્વેસ્ટમેન્ટ કરવામાં આવે તો at the end of your career or towards the end of your career you can have a huge portfolio, you can have a huge gold reserve and you can have a huge land reserve which can create the passive income. So especially for those who are young, invest systematically in whatever is your choice. And take home message માં આપણે બહુ સરસ કહ્યું છે કે don't lay or don't put all your eggs in the single basket. So divide the basket, choose wisely, but do it very systematically, methodically and over a period of long time throughout your career. Another interesting thing which I have observed and started doing recently is investing in land in USA. So those of you who wish, એટલી બધી સારી લેન્ડ અમેરિકામાં એગ્રીકલ્ચરની અત્યારે અવેલેબલ છે અને લોટ ઓફ ચાઇનીઝ એન્ડ જાપાનીઝ હેવ સ્ટાર્ટેડ ઇન્વેસ્ટિંગ ઇન USA. So the land which was not appreciating in USA has started appreciating so well કે 200 એકરનું તમે ખેતર ત્યાં આરામથી લઈ શકો અને એ ખેતર મેક્સિકન કંપનીને ચલાવવા માટે આપી દો તો ઓછામાં ઓછા દર વર્ષે $1.5 થી $2 લાખ પ્રોફિટ તમને એ આપે. સો દેટ ઇઝ વન એવન્યુ. અને $5 લાખ ઇન્વેસ્ટ કરો તો આખા ફેમિલીને વિઝા અને ગ્રીન કાર્ડ બધું મળી શકે છે. સો દેટ ઇઝ એટલે ઇન્ડિયાનું ઇન્વેસ્ટમેન્ટ તો બહુ મહત્ત્વનું છે જ, પણ આઉટસાઇડ ઇન્ડિયા પણ ઘણી બધી જગ્યાએ ઇન્વેસ્ટમેન્ટ કરવાના બહુ સારા સ્કોપ્સ અત્યારે ઊભા થઈ રહ્યા છે. હા સાહેબ. સાહેબ અમેરિકા નહીં સાહેબ એને માટે તો ગોલ્ડ તમારી પાસે હોય, પણ I personally believe US economy and US government is so stable for at least next 100 years કે US investment ને કશું થવાનું નથી for next 100 years. So that's I am very sure about it.
ક્વેશ્ચન ફ્રોમ મી. નિશિતભાઈ અને ગૌરવભાઈ, સાહેબે યુએસએનું કીધું તો હમણાં સોશિયલ મીડિયામાં ઘણા સમાચાર આવે છે કે ચંદ્ર ઉપર જમીન ખરીદી, તો એના વિશે થોડું કંઈક.
અમારે રાજકોટમાં અમે લોકો લઈ લીધી, રાજકોટમાં પછી વેચાઈ ગઈ, રાજકોટમાં લઈ લીધી એમ. ચંદ્રમોર વેચાઈ ગઈ, રાજકોટ વાળા લેવાની ચાલુ કરી દીધી.
મારે શરૂઆતમાં ઓર્થોપેડિક માટેના પ્રશ્નોના ફોન આવતા હતા, હવે કયો શેર લેવો એના માટેના ફોન આવે છે. મિત્રો, શેર ઇક્વિટી એ છે ને, તમે એક મેરેજ કરવા જેવું છે. એ તમે દરિયા કિનારાવાળા દેશોમાં ફરવા જવું એવું નથી કે આ 2 દિવસ જઈ આવવાના આવતા રહ્યા. યુ હેવ ટુ મેરી વિથ ધેમ એમ. એટલે તમે એનો અભ્યાસ કરો, એની બેલેન્સ શીટ જુઓ, એના પ્રમોટર કોણ છે જુઓ, પછી એમાં રોકાણ કરો. ડૉક્ટરો એમ કહે છે કે મારી પાસે સમય નથી એમ, પણ સમય છે ને એ તમારા રસની સાથે સંકળાયેલો છે. તમને રસ ન હોય તો તમારી પાસે સમય નથી. બીજું ખાસ એક કહું કે આપણી ડૉક્ટરની લાઈફ અત્યારે 59ની છે IMN આપેલા આર્ટિકલ પ્રમાણે. એવરેજ IMF એવું કહે છે કે ડૉક્ટર્સ આખા ઇન્ડિયાના 59 વર્ષ જીવે છે. તો આપણે યુએસએમાં તો ડૉક્ટર્સ જેટલા છે ને એ લોકો 40-45 હજાર રિટાયરમેન્ટનો પ્લાન કરે. આપણે 45-50નો રાખીએ એમ. પણ એવી રીતે તમારે ઇન્વેસ્ટમેન્ટ કરવું જોઈએ જેમ અમીબાના સૂડો પડ્યા હોય ને એમ. આપણે 2 હાથ છે, આંખ છે, મગજ છે, એમાંથી કાંઈ ખરાબ થાય તો આપણે કંઈ ન કરી શકીએ. એક પણ વસ્તુ, હું ત્યારે સર્જન છું, મારા અંગૂઠામાં ફ્રેક્ચર થયું એટલે હું ગયો.
Neuro exchange program going on stage. Dr. Nishit and Dr. Gaurav, could you join us on stage for a group picture? A car key has been lost. If anybody finds it, please hand it over to the reception counter. I would like to call upon Dr. Mahavir Singh Jadeja, sir, past President IMA GSB, to honor. Sir, kal ratre 1 કલાક માં કહી દીધું. 10 મિનિટ. To call upon Dr. Panjwani, sir, our GMC observer for the conference. We would like to honor him. Thank you, sir, for your valuable services and for the time you have put in.
So, બધાને ભૂખ લાગી હશે એટલે આપણે થોડું ઝડપથી જઈએ. હવે રિઝલ્ટનો ટાઈમ છે. ઉપર આપણે જે બીજા સાયન્ટિફિક સેશન્સ પોસ્ટર પેપર પ્રેઝન્ટેશનના હતા એનું રિઝલ્ટ આવી ગયું છે. લગભગ there were more than 100 papers and presentations, I mean posters, and we are having a winners over here. So before that I would like to mention the judges over here. The names are Dr. Amit Agrawat, Dr. Hetal, Dr. Panjwani, Dr. Mehul Sanishchara, Dr. Krishna Lakhani, Dr. Rajni Parikh, and Dr. Bharat Dabi, and Dr. Kunal Chandarana. are the judges of these sessions and લગભગ 100થી વધારે પ્રેઝન્ટેશન કે પોસ્ટર્સમાંથી જજ કરવા એટલે એક બહુ મોટું ટાસ્ક હતું જે એમણે સક્સેસફુલી પૂરું કર્યું. અને મોડરેટર આ સેશનના ડૉક્ટર જયેશ સોલંકી અને ડૉક્ટર સુગ્નેશ પરમાર હતા. એટલે બહુ મોટી જોબ એમણે આ ટીમે પૂરી કરી. હવે આપણે વિનર્સને એવોર્ડ આપવાના છે. તો ધ ફર્સ્ટ ઓફ ઓલ I am inviting Dr. Mahavirsi Jadeja sir are there on the stage. Will present the award to Dr. Akshat Shah, UG, the one and only UG presentation. Sir, there were two presentations. Akshat Shah.
You're young people, come on, run to the stage.
Yeah. The next is PG Poster Awards. The second winner. Second award goes to Dr. Rishabh Biradar, and I'll request Kanani sir to present the award. The first winner in this category is Dr. Ashka Karia. Okay, so I request Dr. Samir Bhai. His uncle, her uncle will accept on her behalf. Okay, the next category is paper presentation, PG. I'll invite Dr. Devang Pawar and Dr. Vipul Parekh on stage to present the award. Dr. Gitu Krishnan. First winner, Dr. Gitu Krishnan, please. And the second is Dr. Krishna Priya. So these are the Budding Scientist Awards. So thank you sir.
Dr. Kanani sir, could you stay on stage and share your experiences about the conference? A quick 2 words from you.
IMA GSBના ઇમિડિયેટ પાસ્ટ પ્રેસિડન્ટ ડૉક્ટર મહાવીરસિંહ જાડેજા, IMA ભાવનગરના પ્રેસિડન્ટ ડૉક્ટર વિપુલભાઈ, ઇમિડિયેટ પાસ્ટ પ્રેસિડન્ટ ડૉક્ટર દેવાંગ પવાર, IMA જીમાકોના સેક્રેટરી ડૉક્ટર કેતનભાઈના ગૃહમાં આમ તો 8-10 જણા સિવાય કોઈ ઉપસ્થિત નથી. અમારા સિનિયર મોસ્ટ રિસ્પેક્ટેડ યંગ જનરેશન જમવા જતું રહ્યું. ભરતભાઈ જે અહીં ગૃહમાં છેલ્લી મુમેન્ટ સુધી હાજર છે એના માટે અમે ભરતભાઈના અત્યાર સુધી આશીર્વાદ લીધા અને ગૌરવ અનુભવીએ છીએ. કોન્ફરન્સમાં સાયન્ટિફિક ચેરમેન ડૉક્ટર નિલેશભાઈ, કો ચેરમેન મેહુલ, ચિન્મય, કરુબેન, નિધિબેન, કેડી ભલાણી, તમામ એના આસિસ્ટન્ટ સ્ટાફ દ્વારા 2 દિવસમાં સારામાં સારી સાયન્ટિફિક જે એક્ટિવિટી અને લેક્ચર, વેરિયસ લેક્ચરને છેલ્લે ઇન્વેસ્ટમેન્ટ ખિસ્સે હિસાબ રાખવો એ રીતે વધારે આપણે અહીંથી ગ્રહણ કરીને જઈએ છીએ. તો સાથે સાથે ફૂડ, એકોમોડેશન, ઘનશ્યામભાઈ લાગ્યું કે 1 અઠવાડિયેથી ફાઇલ લઈને રોડે આંટા મારતા હતા પણ રૂમમાં બહુ વાંધો આવ્યો નહીં. સમીરભાઈને હવે અમે તો બધા રિટાયર્ડ થઈ જાય, સમીરભાઈ એક વચ્ચે 1 મહિના દિવાળી સુધી એને બિલ ચૂકવવાના રહેશે, બિલ ભરશે. બાકી ઓવરઓલ બહારના મિત્રોના અમને મેસેજ અને અભિપ્રાય આવ્યા. આ કોન્ફરન્સ ખૂબ, અમે તો જીમાકોન 30 વર્ષથી કાકડિયા સાહેબ એટેન્ડ કરીએ છીએ. હું, ભરતભાઈ, ઘનશ્યામભાઈ, મહાવીરસિંહ. આપણે આપણી કોન્ફરન્સના પોતે વખાણ નથી કરતા પણ સારામાં સારું આપણે બધી રીતે વેન્યુ અને ફૂડ તમામ વસ્તુ હતી. કૌરીબેને લેડીઝ પ્રોગ્રામ એણે નિધિબેને ખૂબ સરસ મેનેજ કર્યો. બધી લેડીઝ હચવાઈ ગઈ, અમારે બહુ વડકા ન થયા. અને હાર્ડ કોપી સોવેનિયર આપણે આ વર્ષથી 2 વર્ષથી બંધ કર્યા, સોફ્ટ કોપી. એટલે ડિજિટલ માટે સુગ્નેશભાઈ ઘણા બધા ગાંધીનગર, દિલ્હી ફોન કર્યા. પછી અમુકના મળ્યા કે ન મળ્યા, મેં કીધું ફોટા મૂકીને સારા અક્ષર લખી નાખે એટલે કમ્પ્લીટ થયું. કેટરિંગ કમિટી ડૉક્ટર રાજેન્દ્ર કાબરિયા, ધવલ સોલંકી, કશ્યપ, નિસર્ગ, એ લોકો યંગ કમિટી હતી, કારણ કે મહિનામાં એ અઠવાડિયામાં 5 દિવસ એ બધા બહાર જમતા હોય છે, એટલે ફૂડ કમિટીથી પહેલેથી એમને સોંપી દીધી, કારણ કે ઊન બાપુ જાય તો રોટલા જ ગોતતી, સમજ્યા? એટલે એ મેનુ પણ સારું રહ્યું. અને રજિસ્ટ્રેશન કમિટી સતત 3-4 દિવસ લગભગ મારા ને સમીરભાઈના મારે ત્યાં 500-500 રૂપિયાના રાતે ગાંઠિયા ખાઈ ગયા કવર પેક કરવામાં, અને બહુ 2 વાગ્યા 2:30 વાગ્યા સુધી કામગીરી કરી, અને અહીંયા પણ કાઉન્ટર વ્યવસ્થિત સાચવ્યા. અને જીમાકોનો રેકોર્ડ છે કે જીમાકોન 2009માં 3 બેગ ઓછી થઈ હતી, આ વખતે એક પણ કીટ ઓછી થઈ નથી. એના માટે અમે ગૌરવ લઈએ, કારણ કે જે કીટ લેવાવાળા હતા એ જ ઓર્ગેનાઇઝર હતા. હા, સાઉન્ડ સિસ્ટમ બહુ સરસ રહે. વિડીયો કેમેરા અમારા ચંદુભાઈ મિસ્ત્રી 30 વર્ષથી મારી સાથે કામ કરે છે, બહુ સરસ છે. એના બધા રાજકોટવાળી ટીમ પણ ખુશ થઈ ગઈ. આપણે ઇનકમિંગ નવા પેશન્ટને આપણે એની પ્રોટોકોલ પ્રમાણે વરઘોડો કાઢ્યો ને સજાવીને મોકલ્યા, આખું વર્ષ કામ કરે. બાકી તો ઓર્ગેનાઇઝ કમિટી લગભગ બધાને ઉધડા બધાને ખૂબ ખૂબ અભિનંદન અને શુભેચ્છા. નિલેશભાઈને, મેહુલભાઈ બહુ સરસ મહેનત કરી. સ્ટોલ આપણે લિમિટેડ હતા, પણ વિપુલભાઈ, દર્શનભાઈ એવું સરસ ગોઠવી દીધું કે એમાંથી આપણને કોઈ ફરિયાદ ન આવી. સ્ટોલમાં ટૂંકમાં જેમાં બગદાણાના મંદિર જેમ મંદિરની અંદર દર્શને જાય એ જમીન જાય, એ રીતે ઇસ્કોન કેમ્પસમાં જે આવ્યા એ કોઈને ફૂડ માટે કે નાસ્તા માટે કોઈને પાછું જવું પડ્યું નથી. એના માટે પણ ગૌરવ છે. વિપુલભાઈએ સ્ટોલમાં ખૂબ સરસ મેનેજમેન્ટ કર્યું. બાકી તો કોઈ બીજું બાકી રહેતું નથી. હું કાકડિયા સાહેબને વિનંતી કરું કે 2 શબ્દો એના વતી કોન્ફરન્સ કે ઇસ્કોન ક્લબ આપણને બહુ સરસ છે. હવે આપણે પેઢીના લગ્ન અહીંયા જ કરવાના રહેશે, અમારા બહુ બાકી નથી રહેતા, પણ દીકરાના લગ્ન ઇસ્કોન ક્લબ આપણા ભાવનગર જિલ્લા માટે સારામાં સારું. આનંદભાઈ, કૌટિલભાઈ અને તમામ સ્ટાફનો આપણે ખૂબ ખૂબ આભાર માનીએ. ખૂબ સરસ ગોઠવણી આપી. જય IMA.
વેલિડિટી ફંક્શનમાં આમ તો બહાર ગામના લોકો અભિપ્રાય આપે ને આભાર માને, પણ હવે આપણે કોઈ વધ્યું નથી એટલે પણ કોન્ફરન્સમાં એક મેહુલભાઈ ને સ્ટેજ કમિટીવાળા સિવાય કાકડિયા સાહેબ પહેલેથી છેલ્લે લેક્ચર સાંભળવામાં એક જ હતા, એટલે સળંગ એમ, એટલે સાચો અભિપ્રાય આપશે. ને કાકડિયા સાહેબને આપણે એ પૂછીએ કે ભાઈ આ પૈસા કમાવા એ સ્કિલ છે કે આર્ટ? એ પણ એટલે આર્ટ છે ખરેખર તો, એવું મને લાગે છે. નહીંતર તો બધા પાસે હોત, સ્કિલ તો બધા પાસે છે. એટલે થોડોક એ પ્રકાશ પાડે. એક નાની વાત કરી દઉં. અત્યારે આ લોકો જે કરે છે શેર બજારમાં આ શેર લેવા અને આ શેર કાઢવા, પણ માણસોની મેન્ટાલિટી કેવી હોય છે કે એક ધાર્મિક પ્રસંગ પૂરો થયા પછી બધા લોકો જતા હતા ત્યારે એનાઉન્સ થયું કે ભાઈ બધા જાય ને તો એક સોનાની મૂર્તિ રામની બધાને આપવાની છે, તો બધા લેતા જજો. એટલે બધા લોકો રામની મૂર્તિ લઈ લીધી. પછી એનાઉન્સ થયું કે ભાઈ રામની મૂર્તિ પંચધાતુની છે અને બીજી એક રાવણની મૂર્તિ છે, રાવણની મૂર્તિ 20 કેરેટ સોનાની છે. એટલે મોટાભાગના લોકો પાછા આવી અને મૂર્તિ બદલાવી ગયા કે ભાઈ રામની તો ઘરમાં ઘણી પડી છે, રાવણની એકેય નથી. એટલે એવી આપણી મેન્ટાલિટી હોય.
ડૉક્ટર જાડેજા સાહેબ અને ડૉક્ટર કાનાણી સાહેબ બંનેને ખૂબ ખૂબ હાર્દિક અભિનંદન, અને આખી કમિટીને પણ કમિટી વતી. અને સૌથી પહેલી વખત મેં જીમાકોન એટેન્ડ કરી સાહેબ આટલા વર્ષમાં. ફ્રેન્કલી હું એક પણ જીમાકોનમાં આવ્યો નહોતો, પણ મને એટલો બધો આનંદ આવ્યો, કારણ કે બધા જ સબ્જેક્ટની અંદર શું ડેવલપમેન્ટ થઈ રહ્યું છે, બીજા બધી બ્રાન્ચમાં શું ચાલી રહ્યું છે, બધું નોલેજ એક જ જગ્યાએ બેઠા બેઠા આપણને મળી જાય એવી ઓપોર્ચ્યુનિટી બહુ રેર. મને ફર્સ્ટ ટાઈમ આઈ રિયલાઇઝડ ઇન માય 35 years ઓફ કેરિયર. એટલે હું આ જ સોફા ઉપર પહેલેથી છેલ્લે સુધી અહીંયા જ બેઠા બેઠા બધા લેક્ચર મેં સાંભળ્યા, એન્ડ આઈ વોઝ સો હેપી. એટલે કાનાણી સાહેબો તમને મારી વિનંતી છે કે હવે પછીથી દરેક જીમાકોમાં હું આપની સાથે અચૂકપણે આવીશ જ. અને જાડેજ સાહેબ સાથે જેટલો સમય પસાર કરવા મળે ને એમાં, કારણ કે એમનું નામ બહુ વર્ષો પહેલાં જ્યારે હું ને સાહેબ સેક્રેટરી હતા એમ એના 2 વખત થયા ત્યારે મેં એમનું નામ મજા પાડેલું, કારણ કે એમની ઇનિશિયલ જ મ ને જા છે, મજા, એમ મહાવીરસિંહ જાડેજા. અને ઓફકોર્સ હું એમાં નથી હોતો, પણ સાંજના એ શબ્દો ઊંધા થઈ જાય છે. પણ હું સાંજે મંદિરે હોઉં અને એટલે દરેક કોન્ફરન્સમાં હું આપની સાથે જ આવીશ, પણ સાંજે સાથે નહીં હો સ્પિરિચ્યુઅલ ગેધરિંગમાં, હું ત્યારે મંદિરે જતો રહીશ. પણ અને અદ્ભુત કોન્ફરન્સ, ઇટ વોઝ અ વન્ડરફુલ કોન્ફરન્સ. આઈ હેવ એટેન્ડેડ ઓલ 35 years ઓલ ઇન્ડિયા ઓપ્થેલ્મિક કોન્ફરન્સીસ, ઓલ ગુજરાત ઓપ્થેલ્મિક કોન્ફરન્સ, પણ આના જેવી મજા મને ત્યારેય નથી આવી. ઇટ વોઝ, અને બધા લેક્ચરમાં હું અહીંયા જ બેસ્યો છું, એક પણ લેક્ચરમાં મિસ નથી કર્યું. સો પ્રોબેબલી સાહેબે જેમ કીધું એ પણ આઈ એમ ધ ઓનલી વન હુ હેઝ એટેન્ડેડ ઓલ ધ સેશન્સ. થેન્ક યુ.
Thank you, sir, for that honest feedback and for being a good student throughout the day.
I'm sorry, the stage committee was wonderful, and especially Nidhiben. I never knew that you are such a good master of ceremony. Wonderful master of ceremony. And as if she has put a Fevicol on the chair, these people never moved. Lunch, coffee break, kyaai gaya nathi. They have been, even they have not taken the washroom break. They have been here, persistently handling the audio visuals smooth and flawlessly. Except for the little delay starting, time management was also very excellent. એટલે જે સેશન જેટલા ટાઈમમાં પૂરું થવું જોઈએ એમ જ થતું હતું, એટલે બહુ જ સુંદર. માય હાર્ટીએસ્ટ કોંગ્રેચ્યુલેશન્સ. એન્ડ
રણજીતભાઈ આમ તો બાઇડેનને મળવા જવાના હતા યુદ્ધ બાબત, પણ પછી પતી ગયું એટલે અને છેલ્લા 3 દિવસની અંદર આપણી સાથે જોઈન્ટ થયા અને આપણને ખૂબ સારી કામગીરી કરી એના પણ આપણે બિરદાવીએ. આખી ટીમ, ખાસ તો મેહુલભાઈની દોડતી ટીમ મોટા મોટી A to Z કામમાં મેહુલભાઈ ક્યાંક ને ક્યાંક પહોંચી જાય. એટલે આખી ટીમના બધા નામ નથી લેતો, બધાને ખૂબ ખૂબ અભિનંદન.
Dr. Pragnesh, sir, we are honored to have you. Yeah, so over to you, sir.
My dear friends from Bhavnagar, it has been, truly speaking, it has been a wonderful experience to be here. And this is not only my opinion. I have interacted with so many people, and everybody feels the same way. Everybody has gone home with very sweet memories of Bhavnagar. And for that, I would like to give my heartiest compliments to your entire team, especially your chief patron, Dr. Bharatbhai Trivedi, whom we respect a lot, IPP of IMA GSB, Dr. Mahavir Singh, Dr. Mansukh Bhai, Ghanshyam Bhai, I'm forgetting the names because I have been given this opportunity suddenly. So I have not prepared anything, but it has been a wonderful experience to be here. And this would be a landmark conference, mark my words. Everybody has, we have attended many conferences in state as well as at national level. But everything was excellent. The scientific programs, the venue, the menu, and above all the hospitality. Hospitality of Bhavnagar, ખરેખર જે એમ કહે છે કે ભાવનગરના લોકો ભાવથી ભરેલા છે, તો heads up to you people. And once again, thank you for giving me an opportunity to be with you. I'll also go back home with wonderful memories of this conference. Thank you. Thank you all. And my heartiest compliments to the entire team. Thank you.
Sir, I think it was because our organizing secretary and chairman made sure that we didn't have an event manager. So everything had a personal touch, whether it was the venue or the menu. I'm very happy that you are going back with fond memories, because memories last forever and never do they die. True friends stay together and never say goodbye. So here's a hello to more adventures and not a goodbye. To do the last honors, may we have Dr. Nilesh Parekh, sir?
બધાનો ખૂબ ખૂબ આભાર. દરેક કમિટીએ ખૂબ સુંદર કામગીરી કરી છે. જાડેજા સાહેબ, કાનાણી સાહેબ અને બધા સિનિયરોનો ઘણો સહકાર સતત મળતો રહ્યો. થોડીક વાત હું સાયન્ટિફિક કમિટીની કરી લઉં કે ઘણી જીમાકોનમાં કે નેશનલ કોન્ફરન્સમાં બી ગયો છું IMAની, કાયમ હોલ ખાલી જોયેલા છે. આ પહેલી વખત ધીસ ઇઝ અ લેન્ડમાર્ક કોન્ફરન્સ કે મેં આટલી ઓડિયન્સ જોઈ હોલમાં, અને બધા ડેલિગેટ્સનો ખૂબ ખૂબ આભાર. ધ સક્સેસ ઓફ ધ સાયન્ટિફિક સેશન, ફર્સ્ટ ક્રેડિટ ગોઝ ટુ ઓલ ધ ડેલિગેટ્સ અને સેકન્ડલી ટુ ઓલ ધ સ્પીકર્સ. જે લોકોએ એટલા બધા સરસ પ્રેઝન્ટેશન આપ્યા અને ટાઈમ લિમિટમાં આપ્યા, એનાથી આપણો પ્રોગ્રામ ઘણો સુંદર થયો. અને જે અમારી ટીમમાં જે સક્સેસ છે આનો, એના બે અમારા સ્તંભ છે, મેહુલભાઈ અને ચિન્મયભાઈ. ઓલ ધ ક્રેડિટ રિયલી ગોઝ ટુ ધેમ. અને મેં એમને સતત 2 મહિનાથી જોયા છે. એ લોકોએ રાત દિવસ જોયા વગર મહેનત કરેલી છે. એટલે ગ્રેટેસ્ટ થેન્ક્સ ટુ બોથ ઓફ ધેમ, મેહુલભાઈ અને ચિન્મયભાઈ, એન્ડ ઓલ ધ 4 એન્કર્સ, જે નિધિબેન, રણજીતભાઈ, ભાલાણી સાહેબ અને કૈરવીબેન, ચારે ચારનો ખૂબ ખૂબ આભાર. એ ઉપરાંત અમારા 2 જુનિયર ડૉક્ટર્સ, ડૉક્ટર હિનલ ગુજરાતી અને ડૉક્ટર ટ્વિંકલ રાજ, સ્પેશિયલ થેન્ક્સ ટુ ધેમ. થેન્ક યુ વેરી મચ. અને હોલ ઓફ ધ ટીમ, જે આખી અમારી ટીમ છે ઓડિયો વિઝ્યુઅલની, અને આઈ થિંક દે ઓલ ડિઝર્વ અ સ્ટેન્ડિંગ ઓવેશન.
So all the resident doctors who are here are from Department of Pediatric, Physiology and Microbiology. So all the 3 department whole residents were here. So I think on behalf of organizing committee, big round of applause for all the residents. All residents please come on the stage.